Okay, assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Okay, good. Kita mula dengan umul kitab Al-Fatihah. Okay, alhamdulillah. Hey guys, you year 5 ke year 3 ya? You guys year 5 ke year 3 eh? Korang dah balik ke? Dah balik sini dah?
Belum lagi doktor.
Bila nak masuk sini?
Katanya ujung bulan 12.
Ujung bulan 12? Alamak. Okay dah, tak apalah. Okay lah. Timekeeping. Satu slide, satu presentation maximum 15 minutes. Okay. So slides yang you rasa tak important, you boleh skip. Kalau I rasa important, then I akan cakap lah kena baca that slide. Is it okay?
Okay, doktor.
So ada berapa 4 presentation
5.
5 lagi lah. 15 minit lah maximum. Okay? Okay, so boleh start sekarang.
Assalamualaikum everyone. Welcome to Neurology Seminar. So this is the topic of our presentation within these 2 hours. So let's start with the first topic, which is Meningitis and Encephalitis by me, Aida Sabrina binti Ahmad Faiz, matric number 1812476. So this is the outline of my presentation. So we'll go through meningitis first, and then we'll go to encephalitis. So meningitis. Meningitis is the inflammation of the leptomeninges, which consists of pia mater and also arachnoid mater. So the incidence is greatest in children less than 4 years old and with a peak of 3 to 8 months old. So it is usually caused by virus, bacteria, but then fungal and parasitic infection are rare. So viral infections are mostly self-resolving, and bacterial meningitis have severe consequences. So the risk factors of meningitis include acquired or congenital immunodeficiencies, hemoglobinopathies like sickle cell disease, functional or anatomical asplenia. So functional asplenia is when there is a splenic tissue, but then they do not work well. This is like, for example, in sickle cell disease. And anatomical asplenia is when there is absence of spleen. And then the other risk factors include cochlear implantation, penetrating head trauma, recent neurosurgical procedures, and crowding, such as in daycare center. So moving on to the etiology of meningitis. So it can be classified into infectious and non-infectious causes. So as I said before, infectious, viral infection is the most common one. It accounts up to 2/3 of the meningitis. And then for bacterial infection, although it is less common compared to viral, it is more severe in children with 5 to 10% rate of mortality. And if the patient survive, there are 10% chance of them suffer from long-term neurological impairments, in which we will discuss after this. And then again, for fungal and parasitic infections are rare. So next slide is the table. So as we can see, there are a few organisms for acute bacterial meningitis, and different organisms affect different age of group. So for the first 3 months of life of an infant, group B Streptococcus, E. coli, and Listeria monocytogenes are the most common cause of bacteria that cause meningitis. And for infants of 1 month to 6 years old, meningitis can be caused by Neisseria meningitidis, Streptococcus pneumoniae, and Haemophilus influenza. So this is the reason why we have vaccination for Hep B, Haemophilus influenza type B. And then for viral meningitis, the most common cause is enterovirus, but then arbovirus and herpesvirus are also important organisms for this, and the others are less common. And then, okay, next, moving on to the next slide, is non-infectious causes of meningitis. So it can be caused by malignancy, autoimmune diseases like SLE, Kawasaki's disease, and sarcoidosis, and chemical exposure like the usage of NSAIDs and intravenous immunoglobulin. So from what I read, the usage of NSAID is that it can cause drug-induced aseptic meningitis, in which they say that it could be due to hypersensitivity type 3 or type 4, because the symptoms of meningitis will be removed when they discontinue the usage of NSAIDs. Okay, now moving on to the pathogenesis of meningitis, specifically bacterial meningitis.
Yeah, sorry, boleh tak you present the previous slides? Kejap, I miss something.
This one?
Okay, this one. Okay, market exposure. Okay. Okay. Proceed.
Okay, thank you. So now let's move on to, am I going too fast? I think it's okay, right? Okay. Now let's move on to pathogenesis. So usually meningitis happens when the virulence factors of the pathogens exceed the host immune defense mechanism. So first of all, there is colonization of mucous membrane. So these pathogens, they possess surface components such as pili or fimbriae that can facilitate adhesion. And they also secrete protease that inactivate the mucosal antibody. And then they will invade the bloodstream. So this is most likely mediated by the interaction of environmental factors, host factors, and genetic factors of the pathogen. So host factors include the risk factors that we have discussed earlier, like asplenic and immunodeficiencies and so on. And then they will survive in the bloodstream. And because these pathogens, they possess a polysaccharide capsule, so they can prevent phagocytosis. And some pathogens also have a binding protein that targets specific complement components. So that can avoid bactericidal activity of the complement system. And then they will survive, and then they can invade the blood-brain barrier. Okay, next, they will invade the meningeal. So the pathogens will enter the cerebrospinal fluid through choroid plexus and meninges, and then they will circulate into the extracerebral fluid, CSF, and subarachnoid space. After they circulate in that, they will multiply to high concentration within hours because of the inadequate humoral immunity in the CSF. So this is specifically like low immunoglobulin and so on. And then, and then there will be generation of inflammatory cytokines. So when the bacteria invade the meningeal, there will be strong inflammatory response towards the infection within the CSF. So there will be a series of injuries that occur with the recruitment of leukocytes, vascular deregulation, vasculitis, and vessels occlusion. So basically, this will lead to the blood-brain barrier impairment. Okay, now moving on to clinical manifestations. So usually meningitis is preceded by upper respiratory tract symptoms, and then we can also find a few other symptoms, like for example, meningeal signs. We can see a knuckle rigidity. So it is the inability to place the chin on the chest, limitation of passive neck flexion, and Kearney and Brodzinski sign. So Kearney sign is when the patient is lying supine with the hips flexed at 90 degrees, but then they cannot fully extend the knee. So for Brodzinski sign, in which there is flexion of both legs when there is passive flexion of the neck. So you can see the picture in the slide. And then there is also a headache, photophobia, and irritability. And then for neurological finding, you can see abnormal mental status, which can range from irritability to confusion to lethargy to coma. And then seizure can also happen in 20 to 30% of the patients. And usually it is generalized seizure, because if there is focal seizure, it may indicate that there is cerebral injury at a later cause of the disease. And then there are also signs of increased intracranial pressure. So for infants, you might be able to see bulging fontanelle or diastasis of cranial sutures. And in older children, you may see headache, diplopia, and vomiting. And there are also late signs of intracranial pressure, which include systemic hypertension, bradycardia, and respiratory depression. And there are also focal neurological findings like motor abnormalities, asymmetry or absent tendon flexes, or cranial nerve palsies. So you can also find petechiae or purpura in patients with meningitis. So in any febrile child, we should assume that the purpura could be due to meningococcus sepsis, and the purpura is more pronounced on the extremities, and they can be preceded by erythematous maculopapular eruption. And then for systemic findings, you may see fever, chill, septic shock, and so on. And this is due to the complications of the bacteremia that usually comes together with meningitis. Okay, now differential diagnosis. Lyme disease, and encephalitis, like viral and autoimmune encephalitis, CNS tuberculosis, syphilis, and leptospirosis. So for investigation, the absence or presence or classic meningeal signs do not actually tell us that this is meningitis or not. So it is important for us to do more investigations. So first we do full blood count, and then we should do CSF examination via lumbar puncture. So this is to confirm the diagnosis, identify the organism responsible, and its antibiotic sensitivity. This is also to differentiate bacterial meningitis from tuberculosis and viral meningitis, in which in the next slide, I have provided the table for CSF findings in 3 of them. However, there are certain contraindications to lumbar puncture, and you can read it in the picture there. So if the contraindications are present, it is suggested to postpone the lumbar puncture until the patient's conditions has stabilized. Or we could perform blood culture or PCR or rapid antigen screen on the blood or urine samples. And then other investigations should also be done, like blood glucose, blood culture, kidney function test, and electrolyte, and so on. So this is the table. I think you can go through it on your own later. So for management of meningitis, so we have preventive measures, which include vaccination for infants in the first year of life. So it is vaccine against Haemophilus influenza type B at 2, 3, 5, and 18 months old. And then for chemoprophylaxis, rifampicin is used to eradicate meningococci from the nasopharynx of the carriers, and it is also given to household contacts to eradicate the carrier state and decrease the transmission of the infection. And then there are also supportive treatment like IV feed if the meningitis is complicated by shock, blood transfusion, anticonvulsants, and adequate cerebral perfusion. So, and then the next management is antibody therapy. So for all patients with meningitis, we should treat them as if they have bacterial meningitis until proven otherwise. So the aim is to sterilize CSF, and these antibiotics are given intravenous for at least 10 to 14 days. And then steroid, dexamethasone, is also given together with the antibiotics, and this is to decrease the incidence of hearing loss, which is a complication that is being caused by meningitis due to Haemophilus influenza infection. And then after that, follow up after treatment, in which we should make sure that the patient have undergone complete neurological evaluation at the time of discharge, especially vision, hearing, and developmental assessment. And then patients should also undergo periodic follow-up and treatment of complications. So moving on to the complications. So there are early and late complications. So for early complications under CNS, we have subdural effusion. So this is common in Haemophilus influenza and pneumococcal meningitis. And then for cerebral abscess, it is the deterioration of clinical condition with the appearance of signs of space occupying lesion. So we can see it in the CT scan. And then for vascular, we have DIC, shock, and SIADH, which is a disorder of impaired water excretion that is being caused by inability to suppress the secretion of ADH. For late complications include hydrocephalus. This is due to inflammatory obstruction of CSF, and then subdural empyema, with the development of increased intracranial pressure, epilepsy, due to focal infarctions and adhesions with underlying cortical irritation, and then mental retardation, cerebral palsy, and learning deficits, and also hearing loss. So this is due to the damaged 8th cranial nerve and the cochlear hair cells. So they can also affect the vestibular organ, and patients also have the risk of ossification, which is the growth of an extra bone in the ear in weeks or months after recovery of meningitis. So this will make the hearing loss even worse. And if we were to treat the hearing loss, it will make it even harder to treat due to this ossification. Okay, for prognosis of meningitis, it is worse in younger patients, and it also depends on the duration prior to antibiotic treatment. Also, Haemophilus influenza, Streptococcus pneumoniae are associated with worst outcomes, and then it also depends on the focal sign. So now let's move on to encephalitis. So encephalitis is the inflammation of the brain parenchyma associated with neurologic dysfunction. So its incidence is highest among infants that are younger than 1 year old, and the reported rates of pediatric encephalitis related hospitalization range from 3 to 13 admissions per 100,000 children per year. So the etiology, they are mostly being caused by virus. So the virus can be transmitted from animal to human, or it can be associated with childhood illness like measles, rubella, chickenpox, and mumps. So in the table, you can see that enterovirus are the most common cause of encephalitis, and it is being followed by herpes simplex virus and arthropoid-borne viruses. So for pathogenesis of encephalitis, so first is direct invasion of the cerebrum. This is by neurotoxic virus like HSV, herpes simplex virus. And then post-infectious encephalitis, there is a delayed brain swelling following a disordered neuroimmunological response to an antigen. So this is like, for example, following a chickenpox. And then slow virus infection like in HIV infection. And then for clinical manifestations of encephalitis, there is a manifestation of viremia like fever, nausea, upper respiratory symptoms, and then manifestation of meningeal irritation and increased ICP, but then these are less severe compared to meningitis. And then manifestations of focal neurological deficits, like disturbed level of consciousness, irritability, abnormal movement, confusion, coma, seizure, paralysis or paresis, and so on. And then manifestations of the complications like epilepsy, mental retardation, and so on. So differential diagnosis include bacterial meningitis. So basically, bacterial meningitis and encephalitis, the clinical manifestations may overlap. So it is important that we do lumbar puncture, and in order for us to see which organism is causing such symptoms. Okay, and then the other differential diagnosis. So for investigation, it is important to do CSF. So in encephalitis, you may see lymphocytic pleocytosis, slight elevation in the protein content, and also normal glucose level. And then we should also do PCR and antibody testing. So this is to establish infectious etiologies of encephalitis, and this is also to detect virus-specific IgM in CSF, because it may indicate CNS diseases. And then we should also do imaging of the brain, in which MRI is more preferred compared to CT scan because it is more sensitive. And then we may see brain edema, inflammation of the cerebral cortex, gray-white matter junction, and hemorrhagic finding in herpes simplex virus encephalitis. And then EEG may also be done, in which it will help us to differentiate encephalitis from non-convulsive seizure activity. And then for management, because the patient might come with us.
I think we can skip management because you guys third year kan? Management just mention just briefly lah, just briefly.
Okay.
Okay, just
So
put like 1, 2, 3, 4 macam tu je.
Okay. So because the patient may come with altered mental status, so it is important for us to stabilize the patient with ABC, airway breathing circulation, and then we should control convulsion, and then we should do something to lower the increase intracranial tension. And then encephalitis, it depends on the pathogens. It depends on the virus. So there are specific treatment for each virus. And then for complication and prognosis, so the symptoms usually resolve over several days to 2 or 3 weeks, and most patients actually recover without sequelae. And severe cases can lead to death or substantial neurologic sequelae. And complications of encephalitis include paralysis or spasticity, cognitive impairment, weakness, ataxia, and recurrent seizures. And for prognosis, worst prognosis is always associated with disease that is being caused by herpes simplex virus, Eastern equine encephalitis, or Mycobacterium pneumonia. And children younger than 1 year of age and children with coma are also associated with worst prognosis. And I think that's it. So this is my reference. And thank you.
Got any questions?
Can I ask one question? In clinical diagnosis or history taking or physical exam, how can we differentiate between encephalitis and meningitis?
Okay, thank you, Musawa, for the question. I think from what I read, because the clinical manifestations may overlap, so we may not like know directly whenever we know whenever we during history taking or physical examination, we may not know directly straight away that, oh, this is meningitis or this is encephalitis. So this is the reason why we need to do more investigation, such as lumbar puncture. Does it answer your question?
Yes, thank you.
Okay, so which one you have to give dexamethasone?
Meningitis, I think.
Encephalitis, can you give dexamethasone?
What
You
is it?
mentioned. Do you mention so meningitis you give steroid, right? Before antibiotic. Okay.
Yes.
So if you've got dilemma whether this is meningitis or encephalitis, so do you need to wait for investigation before you make a diagnosis and before you treat?
I'm not really sure, Doctor.
So in general, okay, if you're confused, because in general, the principle is encephalitis is the inflammation of the brain matter. You know, the brain matter. The brain itself is inflamed. So you would expect more, it will affect more of your cognitive function, your executive function, your cognitive function, your conscious level, rather than meningitis. Okay, meningitis is a sepsis, but in encephalitis, what happens is the brain is inflamed, so most of the time you get encephalopathy. So patient akan datang dengan the typical symptoms in older children is headache, altered behavior, altered mental status. These are prone towards encephalitis. Meningitis, however, they have more symptoms of meningism rather than encephalitis. A lot of them, they don't have all this altered behavior, altered mental status, but they do have seizure, high grade temperature. They are more sepsis than the encephalitis. Even though encephalitis is more neurological problem. But if they can both, for example, you've got a child with seizure, kan? Okay, datang dengan seizure, and then also got history of altered behavior. For example, meracau ke, talk nonsense kan, delirium, or headache, and headache. Then you have to cover both lah, meningoencephalitis. So, and remember, etiology of encephalitis is mainly viral. Okay, more than 90% of time, encephalitis is viral. For meningitis, even though viral is very common, but viral meningitis usually not severe. So patient who came with severe meningitis is most of the time is caused by bacteria. So the treatment is for meningitis is always antibiotic. Encephalitis, you always start with antiviral, especially acyclovir, because herpes is the most common cause of encephalitis. So if you think it could be both overlap, patient got both meningo and encephalitis, then you have to take both lah. You can bagi antibiotic and antiviral. Okay, faham? But in a child is very septic, okay, you cannot give steroid. Okay. Sometimes you cannot give steroids. Or if you want to give, you can give antibiotic first, but immediately to that, you bagi steroid. Atau you bagi steroid immediately just before antibiotic. Okay lah. Okay, ada questions? Kalau tak ada, next lah. Kan ada soalan? Tak ada kan? Okay, next. Okay, laju sikit kan?
Assalamualaikum warahmatullahi wabarakatuh. I Nabiya Farhana binti Rosman with metric number 1818564 and today I will be presenting about febrile seizures. So this is my outline. We will start from introduction up until prognosis. Before we want to know what is febrile seizure, we have to know what is seizure. So seizure is a clinical event in which there is a sudden disturbance of neurological function that caused by abnormal or excessive neuronal discharge that lead to increase in brain activity that eventually will lead to seizure. For the febrile seizure is a seizure in the setting of fever. Usually, febrile seizure is very brief, and the most common one are generalized tonic seizure that occur with rapid rise of fever. And it is the most common cause of seizure in normal children in the age of 3 months old to 6 years of age. Based on the epidemiology, about 3 to 4% of children will have febrile seizures, and the most common are in toddlers. And based on my portal Health KKM, 1 in every 25 children will have at least one febrile seizures, and more than 1/3 of these children will have additional febrile seizures before the age of 5 years old. And for those who have a genetic predisposition, they will have 10% risk to develop febrile seizure because of first degree relative with febrile seizure. The older the child, when the first febrile seizures occurs, the less likely for them to develop recurrent febrile seizures. Based on the study that being done by Department of Pediatrics, University Kebangsaan Malaysia in 1994, it says that boys are more prone to develop febrile seizures than the girls. And the most common age group that is being affected are 6 to 12 months old. Febrile seizure already being classified into 2, which is simple febrile seizure and complex febrile seizure. There are several characteristics that we can help us to differentiate between simple and complex febrile seizure. In a simple febrile seizure, usually affected 75% of the children, and the duration is less than 50 minutes, and the nature for the simple febrile seizure are generalized tonic-clonic seizure. So as we all learn, tonic-clonic seizure have 2 phases, which is tonic phase and clonic phase. So the tonic phase, the muscle will stiffen, they will cry and groan because the air is being forced past the vocal, and they will start to bite their tongue and or inside their cheek. For the clonic phase, their arm and their leg will start to jerking rapidly and rhythmically, and their hips, their knee, and also their elbows started to bend and relaxing. And after the few minutes, the jerking will stop. For simple febrile seizure, they will have no post-ictal gesture. For complex febrile seizures, usually it's affected 25% of the children, and they will have more than 50 minutes of the seizure. And the nature is focal seizure. So focal seizure is based on which lobe are being affected. So it can be frontal, occipital, temporal or parietal lobe, and the sign and the symptom will be based on the lobes. And for the complex seizure, they will have multiple seizures in 24 hours. They are recurrent because complex seizures have more than 1 episode. And but for the simple seizures, there will be no recurrence in 24 hours because simple seizures usually only have 1 episode. And for complex seizure, they have thought paralysis as their post-ictal gasia. So thought paralysis is a temporary paralysis that usually affected one side of the body. And if the seizure more than 30 minutes and continuous seizure without any neurological recovery, so it already been considered as febrile status epilepticus. So there are several etiologies on how febrile seizures happen. So the first one, the most common one is infection. It can be because of the meningitis or encephalitis. It also can be because of urinary tract infection. It can also be because of trauma, if there are any brain lesion due to the head trauma or intracranial bleeding. It can be because of the metabolic condition, which is hypoglycemia, hypocalcemia, hypomagnesemia, hypo or hypernatremia, or because of inborn error of metabolism. It can be because of others, which is poison, drugs, toxic, or hypoxic ischemic insult. So the pathogenesis of febrile seizure can be due to physiological conditions such as infection or any exogenous factors that can elevate the temperature, or it can be due to the genetic susceptibility that can elevate the temperature. So this both will raise the temperature and will impact the ion channels that eventually will give rise to glutamate and decrease in GABA that will increase the excitability and the synchronization of the brain activity that eventually will lead to seizures. So there are several risk factors that can develop to the recurrent febrile seizure or epilepsy. So for recurrent febrile seizure, the risk factors are if the patient has family history of febrile seizure, the age of the patient are less than 18 months, and they have low degree of fever, which is less than 40 degrees Celsius during the first febrile seizure. And the duration between the onset of the fever and the seizure are brief, which is less than 1 hour. If the patient have no risk factor, there will be less than 50% risk of recurrence. And if the patient have more than 2 risk factor, they will have more than 30% of recurrence. And if the patient have more than 3 risk factor, there will be more than 60% risk of recurrence. But for epilepsy, it is very rare. But there are several risk factors that we have to take note. The first one are neurodevelopmental abnormalities such as cerebral palsy. If the patient have complex febrile seizures and they have a family history of epilepsy. For the investigation, it actually depends on the clinical assessment of the individual cases. So we can do a full blood count to look for leukocytosis in infection. We can do a blood urea serum electrolyte used to look for any electrolyte imbalance. We can do a random blood glucose to look for hypoglycemia. We can do a blood culture and sensitivity to look for the causative organism. In the case of infection, but for the serum calcium and magnesium, it's rarely necessary. For the urine analysis, we can do also urine full examination, microscopic examination, or urine culture to rule out any urinary tract infection. And you also can do lumbar puncture in the case of meningitis or encephalitis. So in lumbar puncture, it must be done unless it was contraindicated if the patient have any sign or symptoms that suggest intracranial infection, and the patient have a persistent lethargy and not fully interactive. But it also should be considered if the patient age is less than 12 months, and especially if the children doesn't receive any Haemophilus influenza type B immunization and also pneumococcal immunization. And also it should be considered if a prior antibiotic therapy, because antibiotic, it can mask the signs and symptoms of the disease. For the EEG, it is not indicated in a febrile seizure because EEG, mostly patients with febrile seizure have normal EEG, and it is not indicated even if the patient have a multiple recurrence or complex febrile seizure, because it does not serve as a guide in a febrile seizure, and it also does not predict the recurrence of febrile seizure. For the management, first, parents should be counseled on the benign nature of the condition. So the parents can control the fever by avoiding any excessive coughing or use the paracetamol such as paracetamol or ibuprofen. But this medication does not reduce the recurrence of seizure, just to reduce the fever. And the patient and the parents also should be advised on doing first aid measure during the seizure. So the parents of children with high risk of a recurrent febrile seizure or those who want have a febrile status epilepticus should be supplied with the rectal diazepam. So the parent should be advised on how to administer if the seizures are more than 5 minutes. And if the parent asks what should they do if they shouldn't have seizures beside the medication, we can say that just roll the patient on their side. Just do not put anything on their mouth. Do not restrict the jerking movement, and move any object that can harm the patient, and time the seizure. And not all children need hospital admission. Only several cases that need hospital admission, and the admission will be necessary if you want to exclude intracranial pathology, especially infection. If there are fear of recurrent seizures, to investigate the cause of fever besides meningitis and encephalitis, and just to reduce parent anxiety, especially if they are far away from the hospitals. And there are no prevention in febrile seizure, but for recurrent febrile seizure, we use diazepam. And anti-epileptic are not recommended because they have more side effect than the benefit, and there are no medication that shown to prevent the future onset of epilepsy. And febrile seizure have excellent prognosis. Have an excellent prognosis. They will not affect any neurological deficit or any intelligence of the children. The children that have febrile seizures will have same intelligence as those who does not have febrile seizures. For the prognosis, febrile seizures, as I just now, have a very excellent outcome, have very excellent prognosis. Only 30% in the recurrent on the first attack, 48% recurrence after a second attack, and only 2 to 7% will develop a subsequent febrile seizure or epilepsy. And there are no evidence of permanent neurological deficit following febrile seizure or even febrile status epilepticus. They are normal. So I think that's all for me. Thank you.
Assalamualaikum warahmatullahi wabarakatuh. Okay, ada soalan? Soalan? Actually, my comment is, you have to understand, febrile seizure is a diagnosis by itself. It's not a syndrome. You know, like for example, patient datang dengan fever. So you kata, so what is the cause of fever? What is the etiology of fever? I mean, what is the cause of fever? Can be infection, can be metabolic, can be autoimmune, autonomic dysregulation. Tapi macam febrile seizure is a diagnosis itself. Similar to chronic pain lah. Chronic pain itself is a diagnosis. I'm not sure where did you get the slide. Can you go back to the slides yang etiology of febrile seizure belakang-belakang? Etiology. Where did you get the slides? I mean, where do you get this information?
UMPEDS.
Huh?
University Malaya Pediatrics.
Because you don't actually, there's no such thing as febrile seizure caused by meningitis, or febrile seizure caused by encephalitis, or febrile seizure caused by UTI. That is not right in a way, in a such that, because febrile seizure is a diagnosis of exclusion. Faham tak? Kan? You can get seizure because of meningitis. Okay, you can get seizure because of encephalitis, seizure secondary to UTI. You can get that, but you don't call it febrile seizure. Even though it's a fever-provoked seizure, but it's not a febrile seizure, because febrile seizure is a diagnosis. I'm not sure about the credibility or validity of the reference. Tapi, or I might be wrong, but this is to the best of my knowledge lah. Febrile seizure is a diagnosis for exclusion. Means you rule out everything, then you say this is febrile seizure. Because in a child with brain lesion, you cannot say that the child got febrile seizure. For example, you've got a child with CP kan? You are the CP child. Datang dekat you umur 2 tahun, CP, and then develop febrile seizure. You cannot say this is febrile seizure. It has to be epilepsy. Okay? It has to be epilepsy. Atau you've got a child yang dah 5-6 hari fever, sepsis, and then develop seizure. You tak kata this is febrile seizure. You kata this is meningitis. Faham tak? Or you've got a child yang datang adalah fever, mild fever, and then noted ada hypoglycemia, very severe hypoglycemia. Then you tak poor oral intake, develop hypoglycemia, seizure. You tak sebut this is febrile seizure, you sebut hypoglycemic fit atau hypoglycemic seizure. Okay, because febrile seizure is a diagnosis of exclusion. The principle is to diagnose febrile seizure is very easy. Okay, any child within the age range 3 months to 6 years kan, 3 months to 6 years with normal baseline. Okay, baseline means what? The neurodevelopment normal, the child memang tak ada brain pathology, there's no strong family history of epilepsy, then you can say this is febrile seizure. Okay, faham tak? Unless if the child is, the presentation is not typical, then you have to work out for something else lah. Faham tak? Okay, because you are presenting like febrile seizure is a you are presenting like how to work out if a child presented with seizure and fever atau fever provoke seizure. Dia tak, because febrile seizure is a diagnosis by itself. Okay. Okay. So you cannot say, oh, this patient febrile seizure secondary to meningitis. That is so wrong. Okay, that is so wrong. It's either febrile seizure or meningitis. Okay, ada soalan? Soalan tak? Okay, kalau tak ada, next lah, next.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Can you guys see my slide?
Yes.
Yes.
Alright. So today I will be presenting about childhood epilepsy. So before that, my name is Muhammad Nakib bin Mohsen. My entry number is 1812001. So this is the outline or the content for my presentation. So let's start with the definition of epilepsy and seizures. So basically, epilepsy is a chronic neurological disorder which characterized by a recurrent unprovoked seizures. So in practical definition, and in order to diagnose a patient with epilepsy, there must be at least 2 unprovoked seizures that occur more than 24 hours apart, and 1 unprovoked seizures, and the probability of further similar to the general recurrent risk for at least 60% after 2 unprovoked seizures occurring over the next 10 years. So it can be diagnosed with epilepsy syndrome. While seizures, it is a clinical event in which there is a sudden disturbance of neurological function that caused by an abnormal or excessive neuronal discharge. So the epidemiology, epilepsy is one of the most common chronic neurological condition in children and affects 0.5% to 1% during childhood. So basically, epilepsy is more common during after the first year of life. So below the first year of life, the epilepsy is less common. So we can classify the epileptic seizure types into 4 classes: the generalized seizures, focal seizures, the generalized and focal seizures, and also unknown seizures caused by unknown causes. And so I will only discuss about the generalized seizures and also focal seizures. So generalized seizures, it always have a loss of consciousness or the loss of awareness in the patient. And in generalized seizures, there will be no warning or no aura. So what is aura? Aura is a symptom where the patient experience at the beginning of the seizure. So aura usually occur in a focal seizures only and not in the generalized seizures. So this aura can affect enough of the brain, but it will not enough to affect or interfere the awareness of the patient. So basically in generalized seizure, there will be no warning and no aura. So in generalized seizures, there will be asymmetrical seizures, mean there is a simultaneous involvement of both hemispheres of the brain. So the first one is called absent seizures or petit mal. So in absent seizures, there will be a sudden loss of consciousness, but without the loss of the postural control. So the loss of consciousness only take around couple of seconds, and then they will regain the consciousness, but without a confusion. And the motor sign, there will be a subtle motor sign and not a prominent motor sign. So it will be like a rapid blinking or a chewing motion. So these absent seizures can occur many times in a day, like 100 times in a day. So the patient or the people around the patient will not realize or the existence of these absent seizures in the patient. So they will just misjudge about the patient, like and thought the patient like daydreaming because they lack in the school performance. And these absent seizures can be induced by hyperventilation. So you can check the patient either they have absent seizures or not by ask the patient to blow into to a piece of paper for 2 to 3 minutes. So this hyperventilation will induce the occurrence of the absent seizures. So next is tonic-clonic seizures or grand mal. So this is the most common type. Obviously, there will be no warning or no aura before these seizures to occur. So there will be a tonic-clonic phase, which initially there will be a tonic stiffening that will be followed by clonic phase with synchronous jerking of the limbs. And it also will be, there will be an increase in sympathetic tone, which will increase the heart rate, the blood pressure, and also the papillary size. So the post-ictal phase or so after the seizures attack, there will be, the patient will be unresponsiveness, and they will regain the consciousness within minutes to hours. They might be having a bladder or bowel incontinence, and also there will be a confusion and drowsiness that lasts for 50 minutes or longer. Next is myoclonic, tonic, and atonic seizures. So basically, myoclonic, it is a sudden and brief contraction of muscle. So it can involve one part of the body or the whole part of the body. So for example, the patient might have a jerking movement of hand while they are sleeping. So this myoclonic seizures is predominant in the juvenile myoclonic epilepsy that I will explain later. And next is tonic seizures. So tonic means there is a stiffening of the body, but there is no clonic, which is there is no jerking movement. And atonic seizures, there will be a sudden loss of the muscle tone, and there will be a brief loss of consciousness. So if the loss of consciousness is in a short period of time, the patient will be like nodding. And if the loss of consciousness occur in a long period of time, the patient might fall to the ground and can lead to a direct head injury. And next is focal seizures. So focal seizures, it is seizures that restricted to a limited part of the cortex of one cerebral hemisphere. Means it only involves one part of the hemisphere. In focal seizures, it can have aura, motor features, or loss of awareness. So it can be classified into 3 types, which is focal seizures with aura. So the nature of the aura help to locate where the seizure focus. Means the nature of aura means the sign that that shows by the patient help us to locate where is the seizures generates from. So for example, like if the seizures is generate from the temporal lobe, the aura will be like there will be a altered visual perception, like micropsia or macropsia. So what is micropsia? Micropsia is when the patient look at an object and perceive it as it is larger than the normal size, smaller than the normal size. And macropsia is larger than the normal size. And the most common aura in temporal lobe seizures is nausea and vertigo. So this focal seizure with aura, it can be from the temporal lobe, frontal lobe, or occipital lobe. And next is focal motor seizure. It originates within the motor cortex. So the jerking movement typically start from one side, and then it can spread to involve the other side. It is called Jetsonian Muscles. Like for example, the jerking movement can involve only one side of the mouth or just one finger, and then it can spread to the whole mouth or to the whole hands. So Jetsonian Muscles, basically the the neuronal discharge, it spread from a smaller part of the motor cortex to a larger part of motor cortex, which involve a larger part of muscle. And next is the post-ictal phase for focal motor seizure. The patient might have thought paralysis, which is a transient paralysis of the limbs. And next is focal seizures with altered awareness. So basically, mostly it arises from the temporal lobe, but it also can arise from the frontal lobe. So the preceding aura will be followed by a period of complete or partial loss of awareness within a couple minutes. So usually it is accompanied by speech arrest and often by automatism. So what is automatism? Automatism is a semi-purposeful stereotype motion. So for example, like lip smacking, a dystonic limb posturing, or a more complex motor behavior, like the patient will walking in circle, or the patient might undress themselves. And the attacks may followed by post-ictal confusion or may develop into bilateral tonic-clonic seizures. So next is the causes of the seizures. So basically, in order to diagnose a patient with epilepsy, basically epilepsy is a diagnosis of exclusion after we rule out all the other causes. So basically, in a perinatal condition, hemorrhage and hypoxic ischemic encephalopathy can lead to development of seizures, while infection like meningitis and encephalitis also can lead to seizures. And in metabolic condition like hypoglycemia, hyponatremia, hypocalcemia, and also hypomagnesemia can lead to seizures, development of seizures. Poisoning like drug toxicity like cocaine, methamphetamine, these drugs can cause vasoconstriction and lead to ischemia in brain, and also lead to development of seizures. And others like trauma, like head injury, and also febrile illness. So when we rule out all of these causes, the seizures might because of the epilepsy. So next is investigation. We need to do a blood test. Like firstly, we need to do a full blood count. This is to identify any infection or any allergic, any abnormalities in the full blood count result, because we need to choose an appropriate anti-epileptic medication to the patient. And we also need to check the sodium and potassium level to check any electrolyte imbalance. We need to check the blood sugar level to detect if the patient have diabetes or not, and to detect the kidney and also the liver function test to detect any damage, because electrolyte imbalance, hypoglycemia, and also the damage to the kidney and the liver might contribute to development of seizures. Other than that, we need to do ECG. So basically, in patient with epilepsy, there's a lot of cases where the patient with epilepsy face a sudden unexpected death. So these cases mostly have unknown causes, but in certain cases, there is an association between a cardiac disease with epilepsy. So by doing ECG, we can detect a patient with epilepsy might have a silent coronary artery disease. So when we detect this coronary artery disease, we can do a more specific intervention to prevent the heart failure and prevent the sudden unexpected death. So next is Electroencephalogram the Eeg. So this is indicated whenever epilepsy is suspected. So basically, this is useful in order to categorize the type of epilepsy. And so the result of EEG, if you see any asymmetry or slowing, there will be an underlying structure abnormality. So if you see in the result, there is a sharp wave and spike wave complexes, they might have a neuronal hyperexcitability. So if the result of EEG is normal, you can do a sleep deprived record or a 24-hour ambulatory EEG, also a video telemetry to strengthen the evidence to diagnose the patient with epilepsy. Next is imaging. There is two types of imaging, a structural scan or a functional scan. So structural scan, it consists of MRI and CT scan. So this structural scan indicated if there are a neurological sign between the seizures, mean it only indicated in a focal seizures patient and not a generalized patient, because when we do this structural scan in focal seizures patient, we can detect any tumor, any vascular lesion, or any sclerosis that cause the seizures to occur. So next is functional scan, which is PET and or SPECT. So PET stands for positron emission tomography, while SPECT stands for single positron emission computed tomography. So basically both of these scan, it can detect the areas of abnormal metabolism that suggest of focal seizures. So others investigation like metabolic investigation, it only we need to do if there is a developmental regression, if the seizures is related to the feed and fasting of the patient. And the last one is genetic study. It is indicated for a certain epilepsy syndrome. It is now known to be due to the genetic deletion, because genetic deletion can cause abnormalities in ion channel. So this can lead to seizure development. So next is management. So always begin with explanation and advice to help the adjustment to the condition. We need to provide an education and continuing advice on the lifestyle issues. And one of the most important thing is school needs to be aware of the child condition. So the teacher must be advised on how to manage the children with seizures, since seizures does not have a specific time to occur. And next is drug therapy. Basically, drug therapy, it does not require in all type of seizures. So we need to, in order to administer this drug therapy, we need to detect based on the type of the seizures, the frequency of the seizures, and also the social and educational of the patient, because this anti-epileptic drug has a lot of unwanted side effects. So we should choose appropriate anti-epileptic drug, because some of the drug can worsen the seizures, like carbamazepine. And the goal in the drug therapy is we need to do a monotherapy with a minimum dosage. But in a common clinical practice, usually we use more than one drugs to treat the seizures. And before we prescribe the anti-epileptic drug, we need to discuss with the parents and also the patient about the side effect of the drug, so they're aware about the side effect. And last, we need to discontinue the therapy if the patient is free of seizures for 2 years. And next is other option on how to manage the patient with epilepsy is by doing ketogenic diets and vagal nerve stimulation. So both of these is still poorly understood, but surgery, if we get a good MRI imaging, a good EEG result, and also a functional imaging, we can do this surgery intervention. So, for example, like temporal lobectomy, in order to treat the mesial temporal sclerosis. So next is epilepsy syndrome. These are few epilepsy syndrome that I listed. So the first one is the West syndrome or infantile spasm.
So Nakib, this is very good. This is very important slides. Tapi I think it's a bit too detailed. In fact, the previous one is a bit too detailed, but it's okay. I think you can share this slide with your friend. This is very important. But I think you can read this from the slides. Let proceed dengan next slides.
Oh, and this one is the last part.
Okay, this is the last one. Okay, so these 6 lagi next slide. Okay, so these 6 are very important. You need to know lah, definitely you need to know, tapi tak perlu detail sangat lah kan. Okay, good. Okay, any questions?
I would like to ask a question.
Oh.
My name is Afika. So regarding childhood epilepsy, what is the main diagnostic tool for child? I mean, in adult, history taking is very crucial, right, to diagnose epilepsy. So I wonder, in child, also we do the same or not?
I'm not sure about that because, like, from what I read, it just stated the investigation like same as the adults. So I'm not very sure about the specific tools for children.
Similar to adult. It's EEG. But remember, normal EEG does not rule out epilepsy. Tapi kalau EEG ada findings, then it's good you've mentioned about absence seizure kan. So sometimes patient that who came with absence seizure, then you can provoke. So EEG usually you've got the sleep EEG, you've got provoke EEG using photo, or you can provoke using hyperventilation. So you can do provoke EEG lah. Okay, lagi.
Kita kena ambil history daripada parents ke doktor?
Oh, definitely.
Okay.
Because you have to understand epilepsy is diagnostic based on history tau. You don't diagnose epilepsy based on EEG semua. These are all supportive. Diagnosis is actually from history. Definitely need witness. Better if you can get video recording from parents. That's why epilepsy is one of the most common disease yang people malingering about. You know, sometimes people who seek for welfare, especially in like welfare country kan, macam European country, you get patient who come to see you saying I've got epilepsy and then brought witness. They just want to get benefit. Now, okay, you cut things like that. Because it's very difficult. Because if you go to court, you kata, oh, EEG tak ada findings. Doesn't mean that they don't have it. Okay. And also important, you have to differentiate between, you mentioned automatism kan? Automatism, all this movement disorder dengan seizure. It's very difficult to differentiate, but you have to understand there are actually not all movement your problem kan. Patient datang dengan abnormal movement is seizure. In fact, there can be any other abnormal movement. Okay, ada questions again? Okay, next.
Doktor just nak clearkan. kira kalau patient datang contoh kita suspect seizure, kita buat masa history and then EEG
Yes,
and ada macam blood test, imaging others tu
it depends.
depends. Yang
Okay.
kita buat yang tu history ticket EEG. Okay. Thank you.
Actually, nowadays we differentiate seizure. Means epilepsy can be divided into 3. Kan, Nakib? What are they?
Ya, betul.
How you classify epilepsy?
Based on the seizure type,
What are they?
the generalized seizures.
Okay. Besides that, what other any other way to classify epilepsy? Okay, you can classify epilepsy first by the nature of the seizure lah, the type of the seizure. But nowadays, a lot of time we classify them into mainly the etiology lah. We call it the etiology. So which mean either this is symptomatic epilepsy or idiopathic epilepsy, or this is lagi satu term tu, cryptogenic epilepsy. Okay, ada kan? You come across that term. Okay, this is how we classify them lah. In the past, I remember waktu medical school, I belajar, grand mal lah, petit mal lah, this is so confusing. And then we change it to better English word, generalized seizure, focal seizure, focal with secondary generalization. But now we are, most of time, I think since 2009 macam tu kot, 2000 something, we classified them to symptomatic, idiopathic or cryptogenic. So it depends. If you got a patient, that's why workup for seizure kan, workup for patient with epilepsy must include imaging. Okay, you want to know whether this is symptomatic, which means dia memang ada brain pathology. Because you know, if patient memang got brain pathology, got abnormality in the brain, kan, structurally got abnormality, then these are candidates for surgery. Okay, especially kalau dia focal new problem. And then the second one is cryptogenic. Cryptogenic means they've got strong family history of epilepsy, and we are quite certain this is epilepsy syndrome, but the MRI is normal. Then we call it cryptogenic. We've got no evidence, but we think this is genetic epilepsy, so we call it cryptogenic. And the other one is idiopathic. Idiopathic means MRI normal, family history tak ada, tapi patient ni memang got seizure lah, then we call it idiopathic seizure. Because management will be different. Okay, you have sometimes some of these conditions you have to work on genetic, do genetic workup lah. And then you ask about tadi you kata kena buat tak blood test. It depends lah. Again, it depends. Kalau you ada suspicion, ada family history ataupun nampak ada derangement in VBG ke, the progression looks memang ada developmental regression, ataupun this is a progressive disease, then you have to work out on this lah, all the metabolic and IM. Okay, ada soalan lain? Tak, soalan lain. Okay, kalau tak ada, next. You guys kalau ada soalan, you can always ask me. I mean, even outside the class pun you boleh just text. Atau you boleh tanya Nakib lah, kalau untuk epilepsi, Nakib pandai. Dah present kan? Okay?
Okay. Okay, can you see my slides?
Yes.
Okay, thank you. All right. Assalamualaikum warahmatullahi wabarakatuh. My name is Afrina binti Muhammad Zaidi, and I'll be your second last presenter for this seminar. All right. So the topic will be muscular dystrophy. Okay. So I've divided today's presentation into two parts. The first part, I'll go through the overview of the muscular dystrophy, because muscular dystrophy is actually a group of disorders. It's not a standalone disorder. So we'll just go through the overview first. And then for the next part, I'll go through the most common type of muscular dystrophy, which is Duchenne muscular dystrophy, or DMD. Okay, so let's go to the overview of muscular dystrophy. Now, how do you classify, how do you organize muscular dystrophy in your brain, right? Where is it located, for instance? So, you know, currently you're in a neurology seminar, right? So start here. So this is how Nelson's Essentials classify it. So neurological disorders. So underneath this can be divided into a lot of other categories. For this case, we focus on the weakness and hypotonia category. And then underneath weakness and hypotonia, we have diseases of the upper motor neuron, diseases of the spinal cord, and diseases of the lower motor neuron. Now, this is where muscular dystrophy is located. So you would imagine the presentation would be of the lower motor neuron lesion. So together with these other disorders such as SMA, peripheral neuropathy, myasthenia gravis, and infant botulism. So these, when considered appropriate, this could be your differential diagnosis as well. So what is muscular dystrophy? So muscular, muscle, dys means bad, trophy means nourishment or growth. So muscle bad nourishment, so poorly nourished muscle. In the case of muscular dystrophy, it's usually without nerve or neuromuscular junction damage, unlike neuropathies. So it's usually just muscle damage. So what is the proper definition of muscular dystrophy? So it is a group of genetic muscle diseases characterized by progressive myofiber degeneration and gradual replacement of muscle by fibrotic tissue. So I've highlighted these three terms because we'll further discuss about it later. Okay, so next we'll go to the types and classification of muscular dystrophy. So there are actually a lot of types of muscular dystrophy, but from most references I've checked, they usually say about the 9 major forms of muscular dystrophy. Of course, in this picture, you can only see 6, but it's actually 7 types, 1, 2, 3, 4, 5, 6, 7, and then 8th and 9th I've mentioned here. So let's go through one by one. So the first type is Duchenne, which is the most common type. And then we have Becker muscular dystrophy. So why is it Duchenne and Becker for this? Basically, this picture is telling you what is the which is the main areas of the muscle weakness for each of the types. Okay, so why is Duchenne and Becker goes together? Because these two are actually similar to each other, except for the fact that Becker is less severe than Duchenne, and we'll talk about this. And we'll talk about why in the dystrophinopathies slide later. Okay, so 1, 2, and then the third type is Emery-Dreifuss, and then the fourth type is limb girdle. Fifth is fascioscapulohumeral, so it's fascioscapulohumeral, and then distal muscular dystrophy, oculopharyngeal muscular dystrophy, and then we have congenital muscular dystrophy and myotonic dystrophy. So those are the 9 types of 9 major forms of muscular dystrophy. Okay. So how do you classify muscular dystrophy? Because muscular dystrophy is a genetic disorder, right? So we can classify it into autosomal dominant, autosomal dominant, autosomal recessive, and sex-linked. Particularly in this case, we're talking about X-linked recessive. Now, don't let this list fear you, because it's actually really easy to study this. First, you need to focus on the this sex-linked category, the X-linked recessive. Now, you remember the sex-linked, we have Duchenne and we have Becker. Okay, just now, Duchenne, Becker. And then Emery, you ignore this first. And then you go to the autosomal recessive. Under autosomal recessive, you remember the limb girdle MD. If you want to be specific, it's limb girdle MD type 2. Okay, Emery-Dreifuss, ignore this first. And then for the autosomal dominant, you just put all the other types of muscular dystrophy in here. Okay, and then just put Emery-Dreifuss in all 3 categories, because it can be autosomal dominant, it can be sex-linked, and it can be autosomal recessive. And then I put an asterisk in the distal MD here, because distal MD is usually autosomal dominant, but research says that it could be autosomal recessive as well. And then limb girdle MD type 1, because we have type 2 here. And if you want to be more specific, the MD type 1 is, limb girdle MD type 1 is autosomal dominant, and MD type 2 is recessive. Okay, so that's basically how you generally classify the types. Okay. now let's go to the etiology. Now, don't let this picture scare you, because I used to be scared of this picture as well. I don't know what's going on, but basically, this slide is basically what I want to tell you is that different types of muscular dystrophy may be due to different protein defects. Your main focus should be here, the dystrophin part. So because when there's defect at the dystrophin, it could lead to Duchenne and it could lead to Becker. So because there's defect at the dystrophin, so this is called the dystrophinopathies. Okay, so what is the difference between Duchenne and Becker then? So dystrophinopathies, Duchenne and Becker, in Duchenne is the loss of dystrophin, whereas in Becker is the misshapen of dystrophin. So you would know that because this is loss, then this could be more severe than Becker. And then in Duchenne, the symptoms usually present at earlier age, at the age of 5, whereas Becker, it's usually at the later age, at the age of 10 to 20. Okay. Now, this is something that I've just inserted because I find this interesting for you to take note of, because we can't see actual patients currently, right? So we can just go to YouTube to search for clinical stories. This is a case whereby this boy, this 18-year-old teen, was diagnosed with congenital muscular dystrophy at the age of 7. But the thing is, he has overcome his disability to become a live streaming gamer and gain profit from it. And then he used the profit to help his parents, as well as to pay for his sister's university fees. Okay, so what I like to highlight from this story, you can watch the video later. What I like to highlight from this story is that, number one, this is what his father described. So my son could stretch his arms and legs straight when he was not able to stand up in the early stage of his illness, but now he can only do half of what he was able to do when it comes to moving his arms and legs. So from this description, we know that muscular dystrophy is a progressive disorder, just as what the definition stated. And then I would like to also highlight the impact of socioeconomic status towards patients with muscular dystrophy. So if you look at a lot of clinical stories of those who are dealing with muscular dystrophy, socioeconomic status plays a very important role. In this case, the patient is of the poorer background, so he can only afford a regular wheelchair and a toy car to move around, right? And it's getting worn out already, right? Okay, but if you look at other clinical stories of those with MD, muscular dystrophy, but from wealthier background, you see that they can afford electrical wheelchair. So that is something that I want to highlight as well, because when we meet patients, we need to consider socioeconomic status as well for the management. And then lastly, this is the inspiring quotes from him. So so I proved that I can take some burden of my family to my own effort. Receiving donations is like asking for money, and that does not feel good. So he earns this amount of money with his live streams, and he uses this to help his parents and to pay for his sister's university studies. And his last quote is, "I'm fine as long as I stay positive about life and love my life." So from this, you can be more inspired and can be more inspired to work harder and to provide the best life a patient could live, because their life is beyond their own disabilities. Okay, so that is the first part of the presentation. So we'll go through the next part, which is Duchenne muscular dystrophy, the most common type of muscular dystrophy, and also one of the most common genetic disorders of childhood. So it is said that DMD, Duchenne muscular dystrophy, is affecting 1 in 3,500 male infants worldwide. So that's the most common type of muscular dystrophy. Okay. So as for the etiology, so we know just now, Duchenne is an X-linked recessive disorder, right? So when there's a mutation at the XP21 site, at the chromosome, at the short arm of the X chromosome, this site is responsible to code for a protein called dystrophin. Okay, so just now we mentioned DMD is a dystrophinopathy, right? So the defect is at the protein called dystrophin. So dystrophin functions to stabilize the sarcolemma. What does that mean? So let's go to the pathogenesis. So where are we now? So if you zoom into the muscles and then we zoom into the myocytes, here near the membrane of the myocytes, this is the zoomed in picture. So the function of dystrophin, it connects the actin cytoskeleton here. So this is the binding end here. This is dystrophin, and then it binds to the dystroglycan complex here, and then the dystroglycan complex dekat membrane ni. This one, as you can see, this turbine-like structure. This is bounded to the ECM, the extracellular matrix. Okay, so in normal condition, when muscles contract, this dystrophin can help to stabilize the myofibril. Okay, but then when there's gene mutation that leads to defective dystrophin, usually it's shorter dystrophin where it couldn't bind to the dystroglycan complex. Then when the muscles contract, it could lead to number one, myofibril membrane instability, because there's no connection here. It's like a tiang for your house. Okay, so there's no connection here, so the myofibril membrane is unstable, and then it could also, when the muscles contract, it could also lead to small rips or tears like this of the membrane. So when this happens, there will be influx of extracellular calcium into the muscle fibers. So we have calcium from the ECM, it can go into the myocyte. So what happens is that in the myocyte, we have inactive proteases. So these proteases can be activated when calcium ion binds to them. But when there's more influx of the calcium, so it ended up activating a lot more of these proteases. Okay, and also just take note that not only there's not only influx of calcium ion, there's also efflux of creatine kinase. It's not in this picture, but there's efflux of creatine kinase through these ribs. This is particularly important for the investigation later on. And then, so because there's more active proteases in the myocytes, then this protease, in the normal condition, it degrades the old dysfunctional proteins. But because there's more of these protease, it ended up degrading the new functional protein as well. So it leads to increased muscle proteolysis and eventually progressive muscle degeneration. In younger age though, this degeneration, the muscles can regenerate again, but because there's so much muscle degeneration, it's going so fast, and then the muscles is unable to cope. So there will be gradual replacement of the muscle by fibrotic tissue, fat and scar tissue, it's like that. Okay, but so this fibrotic tissue, unlike muscle tissue, cannot contract. Okay. All right, so let's go to the clinical manifestations of DMD. So infant boys are only rarely symptomatic in early infancy. So they usually, they don't really show symptoms early infancy, but if there are symptoms, it could be poor head control, mild slowness in attaining motor milestones. And then the clinical onset is usually occurs between 2 to 3 years of age, but even though they usually occur at this age, the diagnosis is usually at the age of 5. Okay, so the clinical onset includes delayed motor development, which takes longer to learn to sit, stand, or walk. It usually does not begin to walk until about age 18 months or later, so we need to take note of this. Cognitive and intellectual impairment tend to be slower and clumsier than their peers. Muscle weakness that worsens over time, and delayed speech and language development. Okay, so this is one of the typical symptoms of DMD, which is waddling gait. This is a wide-based gait, and then there's toe walking. So it is focused at the toes. The walking is focused at the toes, and the walk is described as a duck-like walk. Okay, so this is caused by weakness in the gluteus maximus and gluteus medius muscles, and the patient's inability to support a single leg stance. And the child will lean the body toward the other side to balance the center of gravity, and the motion is repeated with each step. So this is how waddling gait looks like. And then we have lumbar lordosis. Lordosis is basically a curvature, extensive curvature of the spine. So this is due to hip extensor weakness. So when there's weakness in the hip extensors, it results in forward tilts of the pelvis, and then to the hyperlordosis of the spine, which is needed to maintain the posture. So this is normal spine, and this is the lordosis of the spine. It's exaggerated. And then toe walking, it's easier to so that the patient is easier to stay vertical with an equinus foot position. So this is equinus foot position. And then progression is gradually child is observed to have increasingly noticeable difficulty with step taking. And then there's frequent falls without actually tripping or stumbling. And then they begin to have problems getting up from sitting or supine position. And there's actually a name for this sign. That is the goer's sign. Okay, so this is when the child, when they want to stand up, they kind of use their hands to just push towards the ground. So they use their hands and arms to walk up their own body from a squatting position to stand up. So this is caused by weakness in the child's proximal hip muscles. Okay, goer's sign. Other clinical manifestations, such as pain in the calves with activity, so progressive enlargement of the heart, also known as dilated cardiomyopathy, because dystrophin is also expressed in heart muscle. Enlarged calf muscles, pseudohypertrophy. It's called pseudohypertrophy because the hypertrophy is not the muscles itself, but it's the fat and fibrous tissue. Okay, and then there's macroglossia or lash tongue. And then other clinical manifestations include upper extremity involvement, which manifests in later stages. So usually it's lower extremity involvement at the first stage, and then it develops into the upper extremity involvement. And then most children need to use wheelchair by the age of 12, and most die of respiratory complications in their 20s or early 30s. Okay, so what are the differential diagnoses? So you can put the other types of muscular dystrophy whenever appropriate, so such as Becker especially, limb girdle muscular dystrophy, and Emery-Dreifuss muscular dystrophy. You can also put dilated cardiomyopathy because it's one of the clinical manifestations just now, and SMA. So if you remember from the overview slide, this is one of the this is listed as one of the disorders of the lower motor neuron. So it can be the differential diagnosis as well. So diagnosis and investigation. So when do we suspect? So if there's positive family history of DMD, Duchenne muscular dystrophy, when there's any evidence of delayed motor milestones in a younger child appear, we need to suspect DMD. But if there's no history of DMD, when a child is not walking by the age of 16 to 18 months, or there is presence of Goer's sign, toe walking or calf hypertrophy, so we need to suspect DMD. Now, to confirm the diagnosis, as mentioned just now in the pathogenesis, when there's small ribs in the membrane, CK can efflux, right? Can go out from the membrane. So there's elevation of creatinine kinase levels, usually very significant, up to 100 to 200 times higher. And then genetic testing for dystrophin gene mutation, as well as muscle biopsy. So when you do muscle biopsy, the normal muscle is like this, but the affected muscles, there's more like fibrous tissue. You can see more fibrous tissue. Okay, and then complications. So I've listed just 3 of the complications. So there's cardiopulmonary failure, and then there's contractures and early wheelchair dependence, and osteoporosis and fracture. So when there's, because heart is also consisting of muscles, right? So there's decreased heart function, cardiomyopathy, and leads to heart failure. And then because diaphragm as well is weakened, so it could lead to respiratory failure. And then loss of muscle mass, inflammation, and fibrosis will require the child to be assisted with wheelchair. And then AFRED for the osteoporosis and the fracture. Osteoporosis is actually the complication when the child is having steroid therapy, if I'm not mistaken. So when there's osteoporosis, there's more chances for bone fracture. For prognosis, the patient may improve between the age of 3 to 6 years of age, but then this is followed by gradual but relentless deterioration. Before the age of 12 years, most patients will lose ambulation, which means they lose the ability to walk without support, and then require non-invasive ventilation, NIV, by late teenage years. So this is an example of NIV, non-invasive ventilation. And then survival into adulthood is now common because we have better treatments now, but survival beyond the third decade is uncommon. Now management, there is still no known cure for Duchenne MD, which is understandable because it is hard. This is a genetic disorder. But so far, currently the aim is to manage symptoms and complications. So we have steroid therapy to slow down the pace of the disease and delay motor disability. We have supportive care, which includes physical therapy, bracing, proper wheelchairs, and treatments of cardiac dysfunction or pulmonary infections. So these are our treatment of the complications of DMD. And then genetic therapy is still under research. This is interesting because one of the proposed genetic therapy is that they wanted to take, you know how virus can inject their own DNA, right? So they are planning to inject to remove the viral gene, the viral gene, and then they want to incorporate the gene that codes for dystrophin instead in the virus. So they are currently experimenting with that. And then also we need to have management for complications of DMD. And then this is the summary of DMD. Okay, so it's a progressive muscle wasting disease. So you can read it later. Okay, so this is my references, and that is all for me. Thank you. Any questions?
Okay, great. So that's very extensive. Anyway, so any questions? Actually, osteoporosis occur in DMD is mainly because of unused lah, because you need to use your muscle to strengthen your bone. Okay, that's why swimming actually not good for your bone. Because you need to weight lift kan. Kalau you ada weakness macam you nak weight lift. Okay, faham. So any questions? There's actually kan DMD is quite promising disease in the sense that first it follows Mendelian inheritance. Okay, this is a single gene defect. It's a single gene defect that caused the disease. So we call it a monogenic disease. That's number one. And second is it follows Mendelian inheritance. So it's not polygenic. There's no interaction with other gene. So you've got it, and then once you got deletion, then you've got it lah. Either Becker's or Duchenne. So there's a lot of genetic therapy is a promising treatment for DMD. In fact, I know that some people, some countries already start genetic therapy in patients with DMD. I'm not sure, however, the successful rate. But for your information, according to Majlis Fatwa, okay, DMD is one of the disease that is abortable. Means if a woman known to carry DMD gene, okay, and they pregnant, okay, you can do genetic testing on the baby, and if found they've got Duchenne, then you can abort them. It is halus for the woman to abort. Oh, ada satu lagi Cerebral Palsy. Datuk dah habis. Oh, banyak kan. Sekali lah, last question, cepat. I don't think this is effective of 2 hours. So you guys okay ke? Nak continue?
Okay, Doctor.
Continue lah. Okay, kan?
Okay, Assalamualaikum warahmatullahi wabarakatuh. My name is Anis. So finally, I'm going to present our last topic for today, which is cerebral palsy. This is the outline for my presentation. We'll start off with introduction. The definition for cerebral palsy is, it is a permanent disorder of movement and posture due to a non-progressive abnormality in the developing brain. Okay, it can occur in 1 to 2 births every 2,000 babies born, and it is 10 times more common among premature and low birth weight babies. So this disease can affect cognition, communication, vision, perception, sensation, behavior of the child, and they can present with seizure disorder also, and secondary musculoskeletal problems. Okay, so there are many causes that can cause cerebral palsy, but most of them, which is 80%, are antenatal in origin. For example, cerebrovascular hemorrhage or ischemia, structural maldevelopment of the brain, genetic syndromes, or congenital infection. And another 10% can be caused by hypoxic ischemia injury that happened before or during the delivery. Another 10% can be caused postnatally. And for example, meningitis, encephalitis, encephalopathy, head trauma, symptomatic hypoglycemia, hydrocephalus, and also hyperbilirubinemia or kernicterus. Okay, so one of the most common cause for cerebral palsy is PVL or periventricular leukomalacia. So it is basically a disease that characterized by focal necrotic lesion in the periventricular white matter. So leuco means white matter, so white matter of the brain, and malacia is softening of a tissue that is caused by necrosis. So you guys can read more about this disease later in the textbook. Classification for cerebral palsy can be classified in a few ways. So the first one is using gross motor function classification system. There are 5 levels. First one is the patient can still walk without limitation, so it is very mild. Second level, walk with limitation. Third, walk using a handheld mobility device, so they need a device to help them walk at this point. And the fourth level, self-mobility with limitation, and they may need powered mobility. For example, wheelchair or the, you can see in the picture. And then the 5th level is transported in a manual wheelchair, so they cannot walk by themselves anymore. Second classification is classification according to neurological features. So different part of the brain is responsible for different part of the body. So the neurological features will depend on which part of the brain that is affected. So there are 3 major types of cerebral palsy. The first one is spastic cerebral palsy, which is the most common type, 70%. It is caused by the damage to cortex, to the motor cortex. Second one is dyskinetic cerebral palsy, only 10%. This is due to damage to the basal ganglia. And the last one is ataxic cerebral palsy, only again 10%. This is caused by the damage to cerebellum. And there is also a mixed type. So so in this type, there is more than one part of the brain that is damaged. Okay, this is a clearer picture, a more detailed picture to each type of the cerebral palsy. So as you can see here, under spastic, there are other 3 more types of cerebral palsy, which is hemiplegia, diplegia, and quadriplegia. So this depends on where specifically at the motor cortex is affected more severely. And okay. So for spastic cerebral palsy, the first type, it involved the cerebral cortex involving pyramidal or corticospinal pathway. It is the most common type. There is increased limb tone or hypotonia and spasticity. It tends to present early in life. There is also hypotonia of trunk and head because they mainly affect the limbs. And then the muscle tone is velocity dependent, meaning the faster the muscle is stretched, then the greater the resistance. So this can be demonstrated during the physical examination. And if we found this, then it is a hallmark of spasticity. Second one, dyskinetic cerebral palsy. Okay, so this happens because of damage or dysfunction in basal ganglia or extrapyramidal pathway. The presentation will be involuntary and uncontrolled movements because the function of basal ganglia is the opposite of that. Okay, and this type of cerebral palsy can also be described as chorea, ethitosis, and dystonia. I will define each of these things later, but basically these are the presentation of dyskinetic cerebral palsy. This type can be commonly caused by hyperbilirubinemia due to rhesus disease of the newborn or hypoxic ischemia, encephalopathy at term. Okay, the third one is ataxic cerebral palsy. It involves the cerebellum. Commonly, it is caused by the genetic cause, but if it is acquired, then there must be injury to cerebellum or its connection. Okay, so the clinical features. I'm going to, okay, for general, there will be abnormal limb and trunk posture, abnormal muscle tone, delayed motor milestone, feeding difficulties with oromotor incoordination. The child will be gagging and vomiting, so that will lead to the feeding difficulties also. There will be abnormal gait and asymmetric hand function. This is just a comparison between normal and abnormal motor development in babies. I got this from the Sunflower textbook, so you guys can read this later. So for spastic cerebral palsy, okay, there are three more types, right? So hemiplegia, it is a unilateral upper and lower limb. Are affected, but the arms are usually more affected. So the child will present with fisting hand, flexed arm, pronated forearm. Pronated forearm meaning it's like flexed and near to their chest. Delayed walking and tiptoe walk or toe heel gait. So the signs are inclonus. I will show you the pictures of this later. Inclonus, a positive Babinski sign of the affected side, increased deep tendon reflex, hand weakness, and also foot dorsiflexion. Okay, for the second type, diplegia. It is actually all of the four limbs are affected, but the legs are more severe. So the upper limb can appear normal. This type also is associated with preterm periventricular brain damage, PVL, which is disease that I mentioned just now. Okay, so the first sign for a child with diplegia is actually when they are crawling, or in Malay, meniarap. They don't use their legs, but they only use their arms. So if you can imagine in the army, the way the army crawl, right? Okay, so that's how they will be crawling. Okay, so the walking will be significantly delayed because it affects the legs more severely. Club foot, I will show the picture later also. Tiptoe walk, and if severe, the patient will have disuse atrophy of the leg and impact growth of the legs. So signs, there will be brisk reflex, inclonus also, bilateral Babinski sign, and also scissoring legs posture. Okay, the third one is quadriplegia. So as the name suggests, meaning all four limbs are affected severely. the trunk tends to have opisthottonous posture. Opisthottonous posture is like an extension of the trunk. I will show the picture later also. And then there will be poor head control, swallowing difficulty, seizure, microcephaly, moderate or severe intellectual impairment. There will be flexion contraction of knee and elbow, meaning the knee and elbow will be flexed at all times. Okay, there the signs are increased tone and spasticity, decreased spontaneous movements, brisk reflex, and positive Babinski sign. So these are the things that I mentioned just now. So you can kind of between the three types, hemiplegic, diplegic, and quadriplegic. So the GIF here, I'm trying to show the inclonus, but I think you cannot see it clearly. But what's actually happening is that the foot of the baby is shaking when it is dorsiflexed. Yeah. Okay, and then opisthottonous posture is this one. The trunk is extended, and this is scissoring posture of the legs. Okay. So the second type, which is dyskinetic cerebral palsy. So dyskinesia means involuntary uncontrolled movement. This type is also known as ethitoid cerebral palsy. So as I mentioned just now, it can be described as chorea, ethitosis, or dystonia. Chorea is irregular, sudden, and brief non-repetitive movements. Ethitosis is slow movement occurring more distally, such as fanning of the fingers of the hand. And dystonia is simultaneous contraction of agonist and antagonist muscle that can appear as twisting appearance. Okay, so their intellect is relatively unimpaired. They present with floppiness, delayed motor development, feeding difficulties, tongue thrust or jelly, prominent drooling, and affected speech. Okay, so these are the pictures. This is fanning fingers, ethitosis, and floppiness. So as you can see here, a normal baby should be looking like this when they are being picked up. This is all in a physical examination. This is just not for fun. Okay, and the last one is ataxic cerebral palsy. It is usually, I remind you again, this is due to the damage to the cerebellum. This is usually symmetrical. Trunk and limb have hypotonia. The patient has poor balance, delayed movement, incoordinate movement, intention tremor. Intention tremor is when a tremor, shakiness, is worse when the muscle is used even more, yeah, okay. And ataxic gait. Ataxic gait is like this, wide-based gait. I think it's like jalan kengkang. Okay, and then differential diagnosis. So first of all, we need to bear in mind is that cerebral palsy is a non-progressive disease. So, but we need to differentiate from other disease that is progressive, because progressive brain disease is more dangerous because they can get worse in time, and maybe we can treat them early so that they won't progress to a worse stage. But so that's why it's important to differentiate between progressive and non-progressive brain damage. So these are some of the differential diagnosis. Basically, they all have a similar presentation with cerebral palsy that involves brain damage, brain developing problem. Okay, and then for diagnosis and investigation. So cerebral palsy is diagnosed clinically, and it is not easy to detect early because as you can see earlier, the clinical manifestation, some of them, even normal babies are doing it. For example, tongue thrust or drooling. So parents may not notice that, and so they might appear normal. Okay, and we must suspect child that to have cerebral palsy if they have the risk factor or etiology that can affect brain. If there is delay development, persistent remain of primitive reflex, less facial expression, and also if they have abnormal gait and posture. So, and then for investigation is not for diagnosis. It is only for us to identify which part of the brain that is affected. So we can do MRI brain, EEG, and hearing and vision screening because these patients have the risk factor to also have a hearing and vision problem. Lastly, management and prognosis. There is no curative treatment for cerebral palsy, unfortunately. So the aim of treatment is only to increase the quality of life. And this will need a multidisciplinary team approach, which involves many specialists and many people. So for medical, we need of course we need to assess the patient before and after the diagnosis. We can give muscle relaxant, for example, diazepam, baclofen, or dantrolene sodium. So orthopedic surgeon can try to correct the deformities if possible. Neurologists can decrease the spasticity or disable dystonic movement by doing anything that they can. Okay, for psychology, they need to help them with their psychological and social problems. For education, the child may need to go to special school, and we need to observe their intellectual progress also for the sake of their future. And for rehab, they need to go to physiotherapy and also speech therapy. For external aid, since they will be having a difficulty in movement, then they may need a wheelchair or splinter or ankle foot orthosis. This is what the child is wearing is ankle foot orthosis. So the prognosis is it based on the pattern of evolving signs and child's development progress. So I remind you again, this disease is not a progressive disease, but the clinical manifestation may appear progressive because as the child grows older, new motor function is developing, right? So it may seem that the disease is progressive, but it is actually not. There is no progressive damage or to the brain, but only the manifestation appears progressive. So that is all from me. Thank you. These are my references.
Okay, any questions? Anyone got questions? Actually, this is a very important topic because you will definitely see this patient in your life and definitely will come in your exam. I think that's all really. If you got no questions, I think that's all. CP and in CP, what important is actually to identify patient at risk for developing CP. Okay, that is more important. For example, like baby pram, those with connectors, itulah baby yang ada trauma. In fact, MVA is one of the most common cause of CP lah. MVA that occur, traumatic brain injury that occur in baby before 3 years old. So these children will have risk of developing CP. Otherwise, I think that's all good. Any other questions? Ada? If not, then we can postpone our class. Any questions, just text me, okay? And make sure you do reading post class. Make sure you do revision. Because neuro exam is something that you have, it's a must know topic, and we've got a lot of patients. No? I mean, you can easily find patient with neuro problem. Even we've got Duchenne, we've got dystrophy, muscular dystrophy here in hospital, and this is not that rare. So we need to know this, especially meningitis, so it's very common. Okay lah, I think that's all. So itu boleh tanggung dengan tasbih kafarah dan surat.
Thank you, Doctor.
You want to share? Pukul berapa you habis tadi?
Pukul 12.10, Doktor.
Siapa dengan siapa?
Dengan Dr. Alwi.
Ya, okay. Start. Ya, topik today sebenarnya. Online present ya? Tak sama?
Tak sama.
May I start, Doktor?
Start ya. You draw apa ya? You draw apa? Year 3 apa?
Group A, Doktor.
Group A. Okay, start.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Today our group will present in respiratory topic, and I'll be presenting
Berapa orang you all semua ni sebenarnya? 37 37?
36 Doktor.
Siapa present nama dia? Muhammad Arman
Muhammad Arman Arif.
Okay, Asma, okay.
Okay, next. Okay, basically this is my outline for my presentation today. Next. For the introduction, I will cover about definition and epidemiology of bronchial asthma. Next. So, bronchial asthma is a medical condition that causes airway path of the lung to be inflamed, swollen, and filled with mucus, and this will lead to some symptom of difficulty of breathing, and lead to recurrent episode of wheezing, breathlessness, chest tightness, and coughing, particularly at night or early morning. And bronchial asthma is a chronic disease, so it will largely interfere with our daily routine. it is often associated with widespread but variable airflow obstruction. That is often reversible. So bronchial asthma is curable, not like COPD. Most of COPD is irreversible, as evidenced by more than 20% improvement in peak expiratory flow rate, or more than 12% improvement in forced expiratory volume in response to administration of bronchodilators based on pediatric protocol for addition. Next. So this diagram is just to show the difference between normal airway and asthmatic airway. In the normal airway, there is no inflammation in the bronchial lumen. There is no mucus. There is no swollen. There is no redness, and also no muscle tightening or bronchospasm. While in the asthmatic airway, the airway lining is swollen and red, filled with mucus, and there is bronchospasm and muscle tightening, and this will lead to narrowing of the lumen and lead to difficulty of breathing that will exhibit symptom of regular asthma such as wheezing. Okay, next. Bronchial asthma is a common chronic disease among childhood. Worldwide, it shows increasing patterns in prevalence based of international study of asthma and allergy in childhood. Prevalence of asthma among school-age children is 10%, and prevalence in Malaysia is plateau. Bronchial asthma is more common among boys and higher among urban and inner city children, and also higher in minority group such as blacks and Hispanics. Next. So what caused bronchial asthma to develop? The etiology of bronchial asthma. Basically, we can divide the etiology of bronchial asthma into two categories, which is intrinsic and extrinsic. Intrinsic is non-atopic asthma, while extrinsic is atopic asthma. Atopic means that a person develop IgE antibody to certain allergen or irritants that will lead to inflammation in the airway path of the lung. While intrinsic is a genetic factor that bronchial asthma prevalence show higher in children with first degree relative that having asthma. While extrinsic, there is many factors such as allergen, environment, infection, weather, exercise, emotional expression, food, occupational, also pharmacological such as aspirin that also can cause asthma.
Yang mana ni? Intrinsic dan extrinsic ni? Aiman?
I think
mana? Buku mana?
Medscape, I think.
Medscape. Okay lah, okay. Tapi there's no classification of asthma at the moment acceptable by authority, but okay lah, you know, use this one. Tapi I don't use that one. Continue lah.
Next. So we go deeply into this factor. For respiratory infection, most commonly is viral infection, and there is also fungal infection that can lead to hypersensitivity reaction, which is exaggerated immune response that will lead to asthma, such as in allergic bronchopulmonary aspergillosis, when the causative fungi is Aspergillus fumigatus, and bacteria and parasite also can cause asthma. For allergic irritants, such just common allergic irritants such as food, house inhalant, animal allergen, mold, dust mite, irritants such as tobacco smoke, which is very dangerous for asthmatic patient, cold air, chemical, perfume, and paint odor. Exercise also can induce asthma. Inflammatory condition of upper airways such as gastroesophageal reflux disease that will lead to the inflammation on the esophagus, and also can contribute to development of asthma. Nocturnal asthma, which is the asthma that is worsening at night, caused by allergen exposure, abnormalities of CNS, and posture-related irritation of airway. Next. So this is pathophysiology of asthma in general. Any trigger factor, whether it is intrinsic or extrinsic, will lead to airway inflammation. And in this inflammatory process, there is hypersecretion of mucus, airway muscle constriction, swelling bronchial membranes, and this lead to bronchospasm, and this will lead to narrowing of breathing passage and exhibit symptom of difficulty of breathing. And lastly, exhibit symptom of wheezing, cough, shortness of breath, and tightness in chest. Next. So we go specifically how in immunology the asthma develop. It start with allergen or irritant that will be phagocytosed by dendritic cell, and this dendritic cell will present this allergen to the CD4+ T cell or Th2 helper cell, and will activate the Th2 helper cell to secrete certain cytokines such as interleukin 4, 5, and 13. And interleukin 5 will activate eosinophil to secrete inflammatory mediators that will contribute to the bronchial inflammation, such as cytokine and leukotrienes. And plasma cell will be activated to produce IgE, and this IgE consequently will bind to mast cell and activate mast cell to secrete histamine, leukotriene, and prostaglandin D2 that will contribute to the inflammation and then narrowing of the breathing passage. Next. Okay, we're moving on into clinical manifestation and complication. Next. So a person may experience regular asthma symptom, or also may experience episodic symptom that may be prone at certain time based on the environmental factors. And this is the classical asthma sign and symptom: shortness of breath, difficulty breathing, cough, also sleep apnea, or this difficulty to sleep at night because of the shortness of breath, wheezing, also chest pain or chest tightness. We also can expect the history of atopy in the asthmatic patient, such as eczema or dermatitis, allergic rhinitis, allergic conjunctivitis, urticaria, food and drug allergies. Also family history of atopy. Next. So the signs of the asthma we can detect based on the inspection, palpation, percussion, and auscultation. On the inspection, we can expect there is altered consciousness, respiratory distress, cyanosis due to lack of the oxygen, due to difficulty of breathing or breathlessness, dry skin, eczema, decreased percentile weight and height, Cushing features due to prolonged usage of steroids such as inhaled corticosteroid. Also hyperinflated chest that will presented with Harrison sulcus or Harrison groove, like in the picture. In the palpation, we can expect CO2 retention, decreased chest movement, decreased vocal formities, or also hyperinflated chest. There is hyporesonant to percussion. There is diminished entry, vesicular breathing with prolonged expiratory phase, generalized expiratory rhonchi, crepitation or crackle in infants in the auscultation. Next.
Yeah. Go back. Jarang patient with asthma develop Cushing Jarang And then okay, tak apa, continue.
Okay, we're moving on to complication of asthma. Number one is status asthmaticus, or nowadays we call as severe acute asthma or severe asthma exacerbation. That is asthma attack that is not resolved by traditional medication, and it may last from minutes to hours, and it is very dangerous and life-threatening. Any hospitalization. So we as a doctor must treat status asthmatic patient with very care. And also asthma will complicate with pneumonia because of the previous lung damage or weakness of the lung tissue due to severe asthma. And this pneumonia, all of these factors will lead to respiratory failure and then atelectasis, which is collapsing of the lung. Next. Diagnosis and investigation. Next. So how we can diagnose asthma in children less than 5 years old? We can diagnose based on this criteria to detect the probability of asthma, whether it's low, moderate, or high. We can ask duration of symptom during URTIs, number of exacerbation, interval symptom between episode or exacerbate, and atopy or family history of asthma. And we can classify based on this factor into the low, moderate, or high probability in developing asthma in children less than 5 years old based on pediatric protocol for edition. Next. So there is many differential diagnoses when we try to diagnose asthma, such as bronchiolitis that will also be presented after this, pneumonia, sinus disease, also gastroesophageal reflux disease that share some similar symptoms with asthma. Next. So investigation of asthma, we can do some important lung function tests. Number one is spirometry test, which is a test when you blow into a machine to measure how fast you can breathe out and how much air you can hold into your lung to assess your lung function. And this spirometry test is very important, and it is a diagnostic test to monitor response to treatment, assess degree of reversibility to therapeutic intervention, and measure severity of asthma exacerbation. And these tests have to be repeated for 3 times to get a valid result. And in typical case of obstructive defect, it will present with normal forced vital capacity, reduced forced expiratory volume, reduced in forced expiratory volume to forced vital capacity ratio to less than 0.8, and reduce forced expiratory flow by more than 25 to 75% of forced vital capacity. Of all of these factors we get during this investigation, we can include the diagnosis of the bronchial asthma. Next. Peak flow meter test is alternative, more simple, inexpensive test that we can do, but it is less reliable and less sensitive, of course, than spirometry test. We also have to ensure maximum patient effort in the peak flow meter. Normal peak expiratory flow rate not necessarily means lack airway obstruction, so it is not a diagnostic test. It is measured in morning and evening. For the exercise-induced asthma, we can ask the patient to exercise. For example, go into treadmill for about 30 minutes, and we can check for the forced expiratory volume 1 because in case of the exercise-induced asthma, typically the FEV1 will decrease during or after exercise by more than 15%, and this onset of EIA is within 15 minutes after vigorous exercise challenges, and it will spontaneously resolve within 30 to 60 minutes. Next. We also can do chest X-ray to investigate asthma. It is very useful in initial diagnosis of bronchial asthma, then detection of exacerbation. Also, we can detect complication of asthma, like I've mentioned before, such as pneumonia and asthma mimic. And most of the time, we can expect to see whether it is normal or hyperinflated lung in the asthmatic patient. Next. This is other investigation that we can do to investigate asthma. Number one is fraction of exhaled nitric oxide.
Para pesakit dan pelawat sekalian, waktu saat
This
zuhur
test,
masuk dalam tempoh 15
you will breathe out into a machine
marilah
that will
kita
detect
bersama-sama
how much
mengucap
nitric
solat
oxide in your breath. That will be a marker for airway inflammation. If high nitric oxide, it means high airway inflammation, but need high cost equipment of the machine. Allergic testing is a simple testing that we can test for the atopy find and histologic finding of the bronchus. We can expect to see eosinophilic infiltration, narrowing airway luminal, bronchial and bronchial epithelial dilation, mucus plug. And in severe asthma, we can expect to see thickened basement membrane due to chronic inflammation, airway remodeling in form of subepithelial fibrosis, and smooth muscle hypertrophy, hyperplasia due to chronic inflammation that will lead to necrosis and lead to fibrosis. Last. Next. Management of asthma. Next. Number one is treatment. We can divide the treatment into long-term control medication, also quick relief medication. Number one is inhaled corticosteroid. And this inhaled corticosteroid, such as budesonide, usually is recommended by FDA to be used only in conjunction with inhaled steroid. For example, there is a combination of formoterol and budesonide named Symbicort that is recommended by FDA to be used for asthmatic patients. But for the inhaled corticosteroid, we may need to use this medication for several days to weeks before we can attain their maximum benefit. Unlike the oral corticosteroid, the inhaled corticosteroid have relatively less risk of developing serious side effect. leukotriene modifiers such as Montelukast, Zafirlukast, and Zoluton. It will help relieve asthma symptom, but in Montelukast, it has been linked to psychological reaction, if such as agitation, aggression, hallucination, depression, and suicidal thinking. If a patient develop this symptom, we have to modify the medication for the patient. And then we have the metylxanthine, theophylline. Even though it is not used quite often like other medication, but this daily pill may help to keep the airway open by relaxing the muscle around the airways, and then decrease shortness of breath. Also, anti-IgE monoclonal antibodies. The famous one is omalizumab that will bind to IgE and inhibit the binding of IgE to mast cell, and then inhibit the process of inflammation that caused by secretion of leukotriene by mast cell. For the quick relief medication, we use in the asthma attack, for example, that need to treat us. Is the quick relief that they act within minutes to relieve symptom. For example, also is to be used for relief.
Habislah. Tak dengar juga Aiman, kenapa? You boleh dengar tak dia?
Tak dapat dengar.
Tak dapat, doktor.
Ya, dia kat mana? Duduk mana?
Tak sure.
Aiman kat mana?
Tak tahulah.
Ya ni, apa kawan sendiri tahu mana duduk?
Penang.
Penang dia hujan ke? Sana tak ada lah.
Dia kata dia pakai Celcom. Line Celcom sana tak berapa baik.
Yes.
Okey, tak apa. Tak apalah. Proceed je lah. Nanti kita go through balik dia punya. Presenter kedua siapa?
Ni doktor.
Present lah. Siapa nama presenter kedua ni?
Nur Syamina. Nur Syamina.
No?
Syamina.
Syamina. Okay.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Nur Syamina binti Syahrun, 1813698.
Syamina kan?
Syamina.
Syamina, bukan Shanina.
Syamina.
Apa maksud dia?
Cerdik. Cerdik.
Cerdik. Okeylah.
Okay.
Cerdik.
So I will be presenting about bronchiolitis. So this is the outline for my presentation today. Okay, next slide. So let us see what is the meaning of bronchiolitis. So bronchiolitis is a disease of small bronchioles with increased mucus production and occasional bronchospasm, and sometimes it leads to airway obstruction. Bronchiolitis is most commonly caused by viral lower respiratory tract infection, and it is commonly seen in infants and young children. If it occurs in infants, it will be in more severe cases. And bronchiolitis is also potentially life-threatening disease. Okay, next slide. So for epidemiology of bronchiolitis, bronchiolitis is a leading cause of hospitalization of infants, and it occurs almost exclusively during the first 2 years of life with a peak age at 2 to 6 months. Many healthy children with bronchiolitis can be managed as outpatient. However, for severely infected patients, as in premature infants or children with chronic lung disease, congenital heart disease, neuromuscular weakness, or immunodeficiency, they will be in higher risk of developing severe bronchiolitis, which can cause fatal. And usually bronchiolitis, it is endemic and occur usually in months of November, December, and January.
The one in temperate country, our country, same.
Same.
But
In other
we have it all over the year. And we have some two peak. One peak is at June, July. Small peak, another peak is at the December, January. Okay.
Thank you, Doctor. For other country, I just want to add some. For other country, usually they occur in winter.
Winter.
Okay, next slide. The causes of bronchiolitis, the primary cause is respiratory syncytial virus, followed with human metapneumovirus, parainfluenza virus, adenovirus, rhinovirus, coronavirus, and rarely mycoplasma pneumoniae. The mode of transmission of this virus, it could spread by contact with infected respiratory secretions. As we already know that infants and children like to touch things, and then they will place their hands into their mouth. So this can cause the infectious organism to easily infect children and infants. Okay, next. So for the pathogenesis of bronchiolitis, the virus will infect the terminal bronchiolar epithelial cells and causing direct damage and inflammation. This could lead to edema, excessive mucus, and necrosis of epithelial cells, and thus it causes obstruction of small airways and atelectasis, or where the alveolar or lung collapse. Okay, next. How does patient with bronchiolitis presented? It is classically present as a progressive respiratory illness, similar like common cold at early phase, with cough and rhinorrhea or nasal discharge. And then it will progress over 3 to 7 days to noisy, raspy breathing, and audible wheezing. They can also present with low-grade fever accompanied by irritability. While in young infants who are infected with this virus, they may have apnea or cessation of breathing as the first sign of infection, because it will be more worsened presentation occur in young infants. Okay, next. So this is the physical examination. Generally, we can see the patient will be presented with sharp, dry cough, and then tachycardia, tachypnea, intercostal and suprasternal retraction, nasal flaring where the nose will be widened and grunting, the noise, and then cyanosis or pallor. So for grunting and cyanosis usually present in more severe cases. Okay, during palpation, we can feel that the liver will be displaced downwards and the sternum will be prominent because there will be hyperinflation of the lungs. And then during percussion, we can get a hyperresonance sound. And then during auscultation, there will be fine late inspiratory crepitation. I'm sorry for the spelling, crepitation, where it can be described as burning wood in the fireplace. And then prolonged expiration and high-pitched wheeze. Okay, next. So this is just a picture of clinical features of bronchiolitis, and usually in infant it can be a severe one. Okay, next. Okay, so for investigation, how can we diagnose bronchiolitis? So bronchiolitis is diagnosed clinically on the basis of a thorough history and physical examination. While for routine laboratory tests, it is actually not required to confirm the diagnosis. So it is just based on clinical exam, the history and physical examination. For pulse oximetry, it is also required where it should be performed in all children suspected with bronchiolitis, where we want to monitor the oxygen saturation. For blood gas and chest radiograph, it is just indicated if respiratory failure is suspected in that patient. And then nasopharyngeal swab for respiratory virus, where we want to identify which virus that cause bronchiolitis. It is also required for cohorting or grouping the hospitalized patient. Okay, next. So this is the chest X-ray of patient with bronchiolitis, where it shows hyperinflation of the lung, where we can see there is flattening of diaphragm, then horizontal ribs, and also increase in hilar bronchial markings. And as I said just now, that chest X-ray is only indicated if we suspect respiratory failure in that patient, and it is rarely helpful in bronchiolitis. Okay, next. Okay, for differential diagnosis, it is difficult to diagnose bronchiolitis and we need to differentiate bronchiolitis with other diseases that associate with wheezing. And it may be difficult to differentiate asthma from bronchiolitis by physical examination because it is similar, where we can hear wheezing. But the major differential factors will be the age of presentation, the presence of fever, and absence of personal or family history of asthma. As we know that asthma usually presented in older children, and they comes with previous wheezing. And for bronchiolitis, usually comes, the patient is less than 2 years old, and they comes with presence of fever. And usually asthma usually comes with family history of asthma. And the other diseases that may also cause wheezing, like foreign body in the airway, and then congenital airway obstructive lesion, cystic fibrosis, exacerbation of chronic lung disease, viral or bacterial pneumonia, and other lower respiratory tract diseases. Okay, next. So this I get from Quick Notes UM. This is the table to differentiate between bronchiolitis, asthma, and pneumonia. So there are some features that we can use to differentiate these three diseases. For example, the age. Usually bronchiolitis occur less than 2 years old or in infants, and asthma usually in older children, and pneumonia can be in any age. The etiology or the causes of the diseases for bronchiolitis is mainly virus. Asthma usually because of allergen, and pneumonia mainly bacteria. Okay, and others, there will be more about clinical features and other things that can differentiate bronchiolitis, asthma, and pneumonia. You can read it after this. Okay, next. So for management of bronchiolitis, this is the guideline for hospital admission in viral bronchiolitis from pediatric protocol. So just focus at the hospital management column. So how can we know that the patient can be admitted to the hospital? First, we need to see the patient is less than 3 months old, and then they have toxic looking. They also presented with moderate to severe chest recession. They also have central cyanosis. We can hear also wheezing and crepitation during auscultation, and they're difficult to feed, having apnea, and the oxygen saturation is less than 93%. And also they categorized as high risk group. Okay, next. Okay, so mainly the treatment for bronchiolitis is supportive treatment, including respiratory monitoring, control of fever, hydration, upper airway suctioning, and if needed, oxygen administration. While for hospitalized patient, we need to give oxygen therapy, where we need to supply humidified oxygen, which is delivered via nasal cannula. We determine the oxygen saturation by pulse oximetry and should maintain the oxygen saturation above 93%. And at the same time, we need to also monitor sign of impending respiratory failure, where there will be increase in partial pressure of carbon dioxide or the oxygen saturation is not maintained and reduced. Second, we need to also give nutrition and fluid therapy. Nasogastric feeding is useful in children who refuse to feed and also to empty the dilated stomach. And then intravenous fluids should also be given for children with severe respiratory distress, cyanosis, and apnea. Okay, next. Bronchiolitis, we need to also give hypertonic saline solution via nebulizer, and it is showed that this hypertonic saline solution, it helps to increase mucus clearance and significantly reduce hospital stay among non-severe acute bronchiolitis. And then inhaled beta-2 agonist, it is can also be used, but need to be carefully give to that patient and need to do regular assessment because of the side effect of beta-2 agonist. And then inhaled steroid can also be used, but all the trials or the what I have read that it consistently failed to provide evidence of the benefit of inhaled steroid when we give in bronchiolitis in patient with bronchiolitis. So it is not recommended. Okay, next is antibiotics. It is also not recommended, but we can give in infants that present with some condition. First is recurrent apnea and circulatory impairment, possibility of septicemia, acute clinical deterioration, high white cell count, and progressive infiltrative changes on chest radiography. Okay, next. Okay, so for complication of bronchiolitis, in most healthy infants, bronchiolitis will resolve without complication. However, for those who born prematurely or who have underlying cardiopulmonary disease or immunodeficiency, they have higher risk of developing complication. And the most serious complication are apnea and respiratory failure. And it followed with dehydration, asthma, and rarely secondary bacterial infection. Okay, next. Okay, so for prognosis of bronchiolitis, most hospitalized children show marked improvement in 2 to 5 days with supportive treatment alone. And most of the cases of bronchiolitis will resolve completely. There is also 1% to 2% mortality rate recorded, and the highest is among infants with pre-existing cardiopulmonary or immunology impairment. Okay, next. Okay, the last one is the prevention. So how can we prevent bronchiolitis to happen? Is by monoclonal antibody to respiratory syncytial virus, which is the primary cause of bronchiolitis. Example, palivizumab. It is given as an intramuscular injection once per month for 5 months, starting before the respiratory syncytial virus season. And it also proved that this monoclonal antibody can reduce the number of hospital admission in high-risk infants. However, this monoclonal antibody is very expensive. Thus, the usage is limited in hospital. Other than that, how can we prevent this bronchiolitis to happen in children? Is where we need to avoid them from close contact with sick people, wash hands oftenly, train them to wash hands, and then cover mouth during cough and sneeze, avoid touching faces with unwashed hands, and usually clean and disinfect surfaces. And lastly, stay at home when they are sick. Okay. I think that is all from me. Thank you. Is there any question?
Any questions? Any questions? So the question next.
Okay. Assalamualaikum warahmatullahi wabarakatuh. I will explain about the croup and epiglottitis in the pediatric patient in today's presentation. So first, this is my outlines for today. The rough topic what I will talk about today. Next, let's proceed to the croup. The croup is also known as acute laryngotracheal bronchitis. As the name suggests, the infection affects the upper airway, specifically larynx, trachea, and the bronchus of the children. And it occurs commonly in children in between 6 months until 6 years old, where the peak incidence is in the 2nd year of life. And the viral croup accounts for over 95% of the laryngotrachea infections, and the most common cause of the pathogen is parainfluenza virus, and the less common cause of the virus is human metapneumovirus, RSV, influenza virus, adenovirus, enterovirus, measles, mumps, rhinovirus, and the rarely caused by the Mycoplasma pneumoniae and Corynebacterium diphtheria. So the pathophysiology of the groups is when the virus invade the mucosa of and will increase the secretions that affect the airway, and the edema will narrow the airway and cause the airway obstruction in the children. Next is clinical features. Clinical features are the barking cough that further will aggravate by crying and coughing. Inspiratory, harsh inspiratory stridor, voice hoarseness, respiratory distress, and this will usually precede, usually precede by fever and coryza, and the symptoms often start and worse at night. However, if the upper airway obstruction is marked, the stridor and the chest respirations disappear. The chest recession will disappear when the child is at rest. And this is the investigations for the croup. Normally, croup is using a clinical diagnosis itself with the diagnosis clue based on the presenting history. And the lab tests really contribute to confirm diagnosis. So we use X-ray to confirm diagnosis for the croup. As you can see here, there is stipple signs, or we call it also known as a pencil point sign, that caused by the supraglottic narrowing. This one is a normal one, and this one is the stipple sign because of the narrowing of the subglottic. Subglottic.
Subglottic.
Sorry. Subglottic in the patient. Next is management and treatment for the.
Belakang sekali lagi.
This one.
Okay, okay. Continue.
Okay.
Forward. Okay.
Okay, this one is management and treatment. First is we must assess the severity of the patient using clinical assessment of croup Wegener. This is clinical assessment of croup Wegener, which I take from the PITS protocol. So we classify the patient based on the severity. Stridor with excitement or at rest with no respiratory distress, then we classify the patient as mild. Moderate when the stridor at rest with intercostal, subcostal, or sternal recession. And the severe if the stridor at rest with marked recession, decreased air entry, and consciousness is altered. And then hospital admissions, basically the croup is mild disease. So not all patients require hospital admission. However, hospital admission may be suggesting if the patient has moderate or severe viral croup, the age of the patient less than 6 months, poor oral intake, sick appearance, or the patient has difficulty to go to the hospital, such as live far from hospital or having a transport problem. And then treatment is to relieve the obstructed. We can use oral dexamethasone or steroid to decrease the swelling. And to treat severe patient, we can use oxygen therapy or oxygen mask, and then we can use nebulized epinephrine. Epinephrine also used to reduce the swelling in the patient. Okay. And next is complication. As I mentioned before, the croup is mostly mild, so most of them does not develop into complication. However, it still can occur. So the complication is hypoxemia and respiratory failure due to the airway obstruction just now, and the bacteria tracheitis due to the secondary bacterial infections. And the prognosis for the croup is usually self-limited disease. The prognosis for croup is excellent, and symptoms usually improve within 3 days, and the mortality is rare in the croup. Okay, so let's proceed to the epiglottitis. Epiglottitis is the intense swelling of the epiglottitis and surrounding tissue. It is caused by the Haemophilus influenza type B, but it can also be caused by other bacteria such as Streptococcus group A, B, and C, and also virus and fungi. And the most common occur in children is age 1 to 6 years old, but it can affect all age group. But however, it's a rare prevalence nowadays because of the Haemophilus influenza vaccine that had been included in our immunization program. And then, but however, even though it is rare, it is very life-threatening and medical emergency if someone was suspected to having epiglottitis. Pathophysiology of the epiglottitis is when the bacteria went to our respiratory system by by direct inhalation, the bacteria may penetrate the mucosa barrier, invading the bloodstream, causing the bacteremia. So this will spread to the epiglottitis and surrounding tissue. So the infection will lead to the acute onset of inflammatory that will cause edema and thus reducing the airway and cause airway obstruction in the patient. And the clinical feature is the patient will have high fever, ill toxic looking child, intensely painful throat that will prevent the patient from speaking or swallowing, that will cause saliva to drool down the chin. This is the cause for 4Ds in the epiglottitis, which stand for dysphagia, drooling, dysphagia, and distress. And then soft inspiratory stridor and rapidly increasing respiratory difficulty, and tripod position. Tripod position, this is tripod position. As you can see here, the patients prefer to sit on his hand and his head is leaning slightly forward and the tongue is sticking outward. Why did the patient do this action? Is because they want to maximize the air entry into the lung because they are having airway obstruction.
To maintain the airway open.
Oh, okay.
Okay. Okay, apa tu?
To maintain the airway open. Okay, doctor. Thank you.
Oh,
okay.
Sama.
Okay. Investigations, primary investigations of the epiglottitis is a clinical diagnosis, and visualizations of epiglottitis can confirm the diagnosis. So as we can see here, lateral neck X-ray showing the thumb sign because of the swollen of the epiglottis. And then we can also use laryngoscopy. As we can see here, the A is the normal one, while B is the epiglottitis conditions. They having cherry red epiglottitis because of the edema and congestions of the supraglottis and treatment. So as I mentioned before, epiglottitis is a medical emergency and life-threatening. So when having patient with epiglottitis, you need to admit urgently and secure airway if she was having airway obstruction. So you can use intubations, and then after you have secured the airway, you can take a blood for the culture purpose, and then started IV antibiotic, and most of the patient will recover completely within 2 to 3 days. And for the complication, it can be because of the bacteria just now, it can spread to other parts such as pneumonia and meningitis, and the airway obstruction because of the respiratory failure just now, respiratory distress just now. And then the prognosis of the epiglottitis is a good prognosis, depends on the time treatment given. And this is the difference between croup and epiglottitis. The onset of croup is over day, while epiglottitis is over hours. And croup having preceding coryza, but epiglottitis doesn't have coryza. And in croup, we have severe barking, while epiglottitis doesn't have severe barking, doesn't have a cough, or maybe have a slight cough. And croup having can drink but no drooling saliva, but epiglottitis cannot drink and yes, have saliva drooling. And then group unwell by epiglottitis is toxic, very ill. And the fever is in group is basically less than 38.5 degrees Celsius. By epiglottis is higher than 38.5 Celsius. And the stridor in the group is harsh while the epiglottitis is soft. And the voice is hoarse in the group, and the epiglottitis is muffled or reluctant to speak. And this is my reference. And that's all. Thank you.
Okay, next. Any questions? Any questions? No question. Okay, next.
Okay, Assalamualaikum warahmatullahi wabarakatuh. So my name is Nurul Aiza binti Zaidi, metric number 1815620. So I'm on to Aiza.
Aiza. Topik.
Childhood pneumonia.
Childhood pneumonia. Okay.
Okay, proceed. Next slide. So this is the outline of my presentation today. Next. So for introduction. Next. So pneumonia is a common condition worldwide, and viruses are the most common cause of pneumonia in younger children, while bacteria are common in older children. But in clinical practice, it is actually difficult to distinguish between viral and also bacterial pneumonia. And in childhood pneumonia is also an important cause of morbidity in resource-rich countries. Next, epidemiology. Next. So there are estimated 120 million cases of pneumonia annually worldwide, resulting in as many as 1.3 million of deaths. And children aged less than 2 years old in the developing country account for nearly 80% of pediatric death secondary to pneumonia. And it is also a major cause of death in all age groups and the main cause of death in children, especially in low-income countries. And pediatric pneumonia is also responsible for death of more than 800,000 young children worldwide each year. And in Malaysia, the prevalence of pneumonia in children below the age of 5 years is estimated to be 28% to 29.3%, which is quite high. So pneumonia is one of the main causes of morbidity in developed country, but in developing country, it accounts for both morbidity and also mortality. Next, moving on to the risk factors. So there are several risk factors. The general one is low weight for age, lack of breastfeeding, failure to complete immunization, sick family members, and then family size, overcrowding. And then it can also be caused when patient is at risk more when they have underlying diseases such as congenital heart disease, bronchopulmonary dysplasia, cystic fibrosis, asthma, sickle cell disease, and neuromuscular disorders. Can also be caused by exposure to cigarette smoke, especially children under the age of 1 year old. And then alcohol and other substances abuse, usually in adolescents, because it may increase the risk of pneumonia due to increased risk of aspiration through impairment of coughing and also epiglottic reflexes. And then immunosuppressive conditions. Next. We move on to etiology and pathogenesis of pneumonia next. So I've divided the etiology according to the age group. So for neonates under 28 years old, they are usually, we can divide them into early onset and also late onset. Early onset is within 6 days, usually because the babies are at risk for bacterial pathogens present in the birth canal. So the most common one is group B streptococci, followed by E. coli, Klebsiella, and Enterobacteriaceae. Virus such as herpes simplex virus and Candida can also cause pneumonia. And late onset such as strep pyogenes, Staph aureus, and also strep pneumonia. And then respiratory syncytial virus, RSV, adenovirus, parainfluenza, rhinovirus, enteroviruses, and also influenza can also cause late onset of pneumonia in neonates. Next is infant less than 1 year old. So RSV is the most common viral pathogen in this age group, followed by parainfluenza types 1, 2, 3, and also influenza A and B. And then we have the less frequent adenovirus, enterovirus, rhinovirus, and also coronavirus. And then children less than 5 year old, virus is also the most common cause in this age group, also by RSV, and then followed by influenza A and B viruses, human metapneumovirus, and the rest as mentioned. And then children more than 5 year old, as pneumonia is the most common typical bacterial cause. And Mycoplasma pneumonia, chlamydia pneumonia, also the etiology that can cause infection in this age group as well. So next, pathogenesis. So just simply, I'm just going to explain briefly.
Tu tak ada pointer ke?
Oh tak, sebab ni orang lain yang present kan.
Ha?
Ni orang lain yang present the screen.
Oh. Kenapa you tak boleh?
Tak, kita orang gabung semua slide tadi, seorang je yang present supaya nak cepat.
Cepat apa?
Nak bagi smooth flow.
Smooth flow. Supaya tak stop ke?
Sebab takut macam sangkut ke apa ke.
Ya, takut. Itulah. So susah sikit lah. Tak tahu mana you nak start daripada mana?
Saya start dengan exposure tengah-tengah tu. Saya just follow dia tu lah. Okay, first we start with the exposure to pathogen. So the pathogens can enter either by inhalation, aspiration, through direct contact, and also aspiration. And then susceptible host, and then it will enter susceptible host, and then these are determined by the risk factors that I've mentioned before. And then once they gain entry to the host, they will infect and proliferate in the lower respiratory tract, which can cause pediatric pneumonia, which is the inflammatory response to proliferation of microbial pathogens at the alveolar. So this can cause a local inflammatory response and also systemic inflammatory response. So for the local inflammatory response, it can cause accumulation of plasma exudate and also irritation of the structures, which can cause reflux pain. So patient can also present with acute abdominal pain. And then due to the accumulation of plasma exudate, it can cause irritation of the airways, can cause coughing, crepitation, decreased breath sounds, and then it can also give different pattern when we do chest X-ray, such as interstitial pattern and also lobar pattern. And then for the systemic inflammatory response, it's just increased respiratory drive, causing tachypnea and also causing fever. Then move on to the clinical manifestation. Next slide. So history of presenting illness is very important in pediatric. So for newborns with pneumonia, they can present with poor feeding, irritability, and grunting, because patient at this age, they rarely cough, so they present with the grunting. And then in the first months of life, I'm so sorry if you can hear the knocking sounds. In the first months of life, coughing is the most. Saya tak tahulah siapa yang bertukar.
Ya, okeylah.
Aduh. Okay. And then at this first month of life, cough is the most common presenting symptom of pneumonia. They may also have a history of previous lower respiratory tract infection. And then in older infants, can present it with cough, fever, irritability, decreased feeding, and we see less grunting in this age group. And the infants with bacterial pneumonia are often febrile, but viral pneumonia or pneumonia caused by atypical organism, they may have low-grade fever or febrile. So the parents or the caretaker may complain of noisy breathing from the baby. So we might indicate wheezing. And then toddlers and preschoolers can present with fever, cough, and vomiting, and also history of upper respiratory tract illness is also common. And similar in older children and adolescents as well. And they can also present with constitutional symptoms such as headache, periodic chest pain, and vague abdominal pain due to the referred pain just now. And then we need to also assess a few other histories such as travel history, immunization status, and also the medication such as antibiotic therapy before. So next slide. So I'm not going to explain this, but these are, I'm not going to explain, but these are the historical feature that you need to ask if patient, if suspected of pediatric pneumonia, because it might give a lot of clues to the etiology. Okay, so next. So for general assessment, first in the young, we need to assess the ability to attend to the environment, to feed, to vocalize, and to be consoled. And then assess also the state of awareness, cyanosis, and a willingness to eat or drink. So, and then use of accessory respiratory muscles, such nasal flaring, grunting, severe tachypnea, and retraction. So these are very important because it might indicate signs of respiratory distress, in tachypnea, retraction, and also hypoxemia, which is less than 90% peripheral arterial oxygen saturation, and also the above mentioned before. And then oxygen saturation, definitely oxygen saturation should be measured if in any child with increased work of breathing. And then but note in mind that infants and children with hypoxemia may not appear cyanotic. And then, but hypoxemia is definitely a sign of severe disease and indication for admission. So for the vital signs, the most prominent one is tachypnea, followed by fever. Okay, so next. For the respiratory examination, so on percussion, they might have a dullness at the affected site. Okay, I'm sorry, it's supposed to be on palpation. There will be increased tactile femmeters. And then on auscultation, presented with crepitation and also wheezing. So there are few suggestive criteria of consolidated lung parenchyma, such as decreased breath sounds, presence of bronchial breath sounds, dullness to percussion, and also whispered pectoriloquy. And then suggestive of vision, such as chest pain with splinting, dullness to percussion, distant breath sounds, and also pleural pressure rub. But the classic signs of consolidation, such as dullness on percussion, decreased breath sounds, presence of bronchial breath sounds, are often absent in young children. Next. So definitely when we need to assess the severity of the child. So according to the table, so age less than 2 months, it's already indicates severe pneumonia. I will explain further later. And then it's divided into severe pneumonia, very severe pneumonia in age less than 2 months, and then 2 to 5 years, mild pneumonia, severe pneumonia, and also very severe pneumonia. So in order to assess the tachypnea, we can follow the table below. So next. Okay. So for investigations.
Di belakang balik semula. Oh, issue 2. Well, okay. Okay.
Okay, so for investigation, note that for pneumonia, mainly we would diagnose them through clinical diagnosis and also through the HOPI. But when we do investigation, usually when patient is hospitalized. So what are the criteria for hospitalization? So first one is children aged 3 months and below. No matter what the severity is. So once we suspect pneumonia, admit straight away. And then fever more than 38.5 degrees Celsius, refusal to feed and vomiting, fast breathing with or without cyanosis, tachypnea, and the associated systemic manifestation, failure of previous antibiotic therapy, recurrent pneumonia, and also severe underlying disorders such as immunodeficiency or maybe heart condition. And then investigation. First, we measure the level of hypoxia, the level of oxygen by pulse oximetry. And then we can also do non-invasive bedside testing, such as nasopharyngeal swab assays to check for the influenza, RSV, or human metapneumovirus, if available and appropriate. And then because this can minimize unnecessary imaging and also unnecessary antibiotic treatment. And then full blood count, mainly we will check the white blood cell count. So there will be increased counts, predominance of the polymorphonuclear cells, mainly neutrophils, suggest bacterial cause, and then leukopenia suggests either viral or severe overwhelming infection. And then inflammatory markers such as ESR and CRP rarely help to distinguish between viral and bacterial, but we do that to obtain the trend of disease progression and serve as prognostic indicators. Next. So for chest radiograph, it is only indicated when clinical criteria suggest pneumonia, and it is also not necessary in children with mild uncomplicated pneumonia. So it is obtained only in children who require hospitalization and those whom the diagnosis is uncertain or severe, complicated, and recurrent pneumonia. So these are the indications for chest X-ray, severe disease, to confirm or to exclude the diagnosis. If the clinical findings are inconclusive for hospitalization, because we need to document the presence, the size, and also the infiltration of the lung, and also to evaluate potential complications. And then the rest, such as exclusion, and also to assess the complications. Okay, next. So these are the pictures of chest X-ray. The left upper one is right lobe consolidation, bacterial pneumonia, and right lower lobe consolidation in a patient with bacterial pneumonia. And the below one is a radiograph from a child with a round pneumonia. So round pneumonia is usually seen only in pediatric patient. So you can see on the right lung, there's a round opacities well defined. So they represent the regions of infected consolidation. Okay, okay. And the right one is to show the bilateral ground glass abnormality. Okay, so next slide. Okay, so these are the extra investigation that can be done. Blood culture to determine the precise etiology, but the sensitivity is low. So the positive blood culture is only in 10 to 30% of patients. So we do this when patient comes with severe pneumonia or when the antibiotic patient does not respond to antibiotic. Then pleural fluid analysis only when there is significant pleural effusion, and serological test when patient is suspected with atypical pneumonia. Next. Next is complications. Okay, next. So patient might have a pleural effusion empyema, necrotizing pneumonia, lung abscess, pneumatosis, and also hyponatremia. Okay, next. So management. Next. So for outpatient management in children with mild pneumonia, they have tachypnea, but there is no chest indrawing, there's no retraction. So we just give oral antibiotics and also educate the parents or the caregivers on the management of fever to prevent dehydration, also to identify signs of deterioration. And we should also assess the patient in 2 days or earlier if condition is getting worse. So the table is mm, how do you say recommended antibiotics. Okay, next. So for inpatient management, so for children with severe pneumonia, the suggested antiviral agents are listed. First line, second line, third line, and also other agents. And then second line antibiotics will need to be considered when there are no signs of recovery. Patients remain toxic and ill with spiking temperature for 48 to 72 hours. Admitted with severe community-acquired pneumonia. So these patients usually receive parenteral antibiotics, and in severe cases of pneumonia, can also give combination therapy with second or third generation of cephalosporin and macrolide. And this also used, macrolide antibiotic is used in pneumonia for mycoplasma and chlamydia as well. So next is just the supportive therapy. So we give fluids because we need to withhold the oral intake when the child is in severe respiratory distress. But in severe pneumonia, the secretion of ADH hormone is increased. So dehydration is uncommon. So we need to avoid overhydrating the child, as this can cause hyponatremia, as mentioned as one of the complications. And then oxygen, it should be given when the children are restless and tachypneic to maintain the partial pressure of oxygen more than 95%. And then temperature control, give paracetamol to reduce the fever. And then chest physiotherapy. So this assists the removal of the tracheobronchial secretions. So it can remove airway obstruction, increase gas exchange, and reduce the work of breathing for the patient. And then lastly, cough medication, but these are not recommended as it can cause suppression of the cough, which may interfere with the airway clearance. I think that's it. These are my references, and thank you.
Any question?
So,
No. Okay, for the topic childhood pneumonia, it's good if you can divide bronchopneumonia, lobar pneumonia, and the atypical pneumonia, especially on the clinical and on the chest X-ray. And then you know the management a bit different, can be a bit difference. The antibiotic also can be different. You know lobar pneumonia tak? Bronchopneumonia. So diagnosis will be right lobar pneumonia or that or the first the X-ray show just now is a lobar pneumonia. And LIP is not considered as pneumonia per se. Pneumonia is a consolidation of the alveoli. Okay. The chronic epiglottitis okay, bronchiolitis okay, bronchial asthma. In bronchial asthma, you must able to understand the difference between the background asthma and acute exacerbation. So management are not same, presentation also this not same. So asthma is chronic disease. So it is a chronicity of the disease result in background symptoms, signs and symptoms, asthma. But in between, the child can have acute exacerbation of bronchial asthma. Immediately, a sudden bronchospasm of the airway result in dyspnea, shortness of breath, tachypnea, and then increased intercostal recession and hypoxia. There is acute exacerbation. Management acute exacerbation is another thing. How to manage, because you need to decide mild exacerbation, moderate exacerbation, and severe exacerbation. While the background asthma, you have to decide is it a well controlled, partial control, or good control. The description understanding is little bit is in your PICS protocol can tell you a little bit about the difference between the background asthma and acute exacerbation. Okay, any question? Any question tak? Tak ada? Kita ada, okay, we sort here, finish ya. Markah semua I tulis nanti I hantar lah. Semua tulis. Banyak beberapa group lah I tulis. Okay Okay.
Thank you, Doctor.
Thank you, Doctor.